The recording will be posted on the board's webpage shortly after the meeting. TBW may also be recording this meeting and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the materials. Sue Birch, Chair of the Healthcare Cost Transparency Board, will now call the meeting to order.
Welcome, board members. That fancy gavel. It's now 2:04 p.m. and I am calling the May 15th board meeting of the Healthcare Cost Transparency Board to order. I want to welcome those of you that are here in person. And for those that are joining or maybe can't see, we have in the room, and we'll do roll call here in a minute, but we have Kim Wallace, Jane Beyer, Eileen Cody, myself, Sue Birch, the chair, and Ingrid Ulrich, board members. And then we'll do roll call in a minute. We got a really large agenda, and I really appreciate that everybody carved out an extra hour that will give us time to keep focusing in and really elevating this work of moving towards greater healthcare cost control. We are going to focus heavily on data. By the end of the day, our brains are going to hurt from hearing from all of our data experts. And we're going to focus in on hospital costs and the profits report. And then we will have our ASI DEX report. And the second part of our meeting is going to move into the strategic levers that we continue to work on so that we can continue to work in this area of cost control. We've reviewed and discussed several sources of data since our commencement. For example, I remind you the cost driver analysis and the benchmark. I want to just really point out that there will be several different data products that come before us. They will continue to show us about the trends and the prices, the market, and we'll see things at the state, market, and consumer level. And despite the differences in the data sources and the way the data is being utilized, the data is telling us the same story. Healthcare costs are rising at a rate faster than inflation. And we simply have to understand why, and we have to be dogged about coming up with strategies to slow this growth. As we know, rising healthcare costs are one of the biggest reasons people delay or forego healthcare. They're making healthcare costs an underlying barrier to access for many. We continue to hear significant complaints and concerns from individuals. Stories are heartbreaking. And if healthcare costs continue at this pace, the gap between how much money Washingtonians have to spend in order to receive their healthcare will only widen. That's why here in Washington, we need this board to keep identifying solutions, to keep addressing these rising healthcare costs, and to really be courageous about what we need to do. We are also today going to begin discussing two of our identified strategic levers for further examination. Our HMA facilitators and consultants are going to be helping us in those conversations. Before that, we're going to start actually here with a roll call, and then we'll talk a little bit more about the agenda. So I do want to just celebrate some more good news, though. I think many of you saw, I think it was last week, that the U.S. News and World Report ranked Washington number 10 for healthcare in the areas of healthcare access, healthcare quality, and public health outcomes. So for those that continue to say we aren't doing enough, we are in the nation, continued to be ranked in the top tier. We're getting a lot more value, but I think we can do better. But we got to celebrate little successes along the way. All right, let's do a roll call. Jane Beyer here, Eileen Cody here, Lois Cook. I believe Lois is recovering from surgery, she told us.
Yes, I think she is going to be available online, but she is recovering from surgery, so she may not be.
Okay, Lois, if you're listening in, we're wishing you a speedy recovery, and we'll watch for her. Bianca Frogner. Is Bianca online?
She is. She's just boarding over now.
Bianca, if you'll open up.
Just having a little
Oh,
bit
she
of a
raised her
Zoom-
hand. Let the record reflect she is definitely raised her
Zoom
hand.
issue. They're not.
I'm sorry, I've now just been entered in as a panelist, so I just got access.
Great.
Thank you for letting me join.
Okay, Jody Joyce. Did we get anything from Jody?
She is here.
Okay. Jody is coming over as well. I'll keep moving on and then Jody jump in. Greg Marchand? Okay, Greg, thank you for signaling to us that you are here. I can't look at the screen. Talking and read at the same time. Ooh, I'm gonna get motions. Okay, thanks, Greg. Mark Siegel.
No, and I did get a bounce back from Mark Siegel that he was out of office.
Okay, Margaret Stanley.
She is here.
Welcome, Margaret. Ingrid Ulrich.
Here, present.
Thank you. Kim Wallace.
Here.
Great. Carol Willems.
Here.
Hi, Carol. And Edwin Wong.
I am here.
Great. So I think we're waiting to see if Lois or Jody pop up and
I see Lois. She just.
Lois is on.
And Jody's here too. Thank you.
Great. Welcome to both of you. All right. So before we get into the materials, I want to just take you through a brief overview. I actually think we might need to switch the order because Dr. Zerzan said she's delayed, if there's any way we could flip, but we are going to, depending on who comes in first, we're going to have a presentation from our very own Dr. Judy Zerzan-Hull. She chairs our primary care committee and she's going to provide a preview of the potential policy options being evaluated by that committee. But if one staff can trigger and see how far out she is or what her delay is. Then we're going to move into a presentation and discussion of the financial analysis of the Washington hospitals. This is done by John Bartholomew and Tom Nash and Associates. Then we are going to discuss the strategic lever focused on business oversight, including the topic of mergers and acquisitions, private equity, investments, provider ownership, and closures. And then we'll discuss the second strategic lever identified for further examination, the issue of facility fees. And after that, we're going to follow up on our discussion of potential levers regarding the consumer medical debt from Noel Levy's presentation last month. We're going to have a presentation and discuss the analytics support initiative, this DEX report. We'll be hearing from Joe Dielman. And then we're going to have recommendations from the nomination committee. And then lastly, we will open it up for public comments and then we'll wrap up and conclude the meeting and set the dates for our next meeting. So we got a packed agenda and I think with that, we're gonna, did we hear back from Judy yet? Okay, and then do we have John and Tom on?
I did see John.
So John, if you're listening in, we may be switching the order and having you, oh, I'm sorry.
I see
Meeting
Tom.
summary, let's do that first, okay. All right, so if you'll go to the second tab, this is the meeting summary of our last board meeting. As a note, the recording of the last meeting is posted on our webpage for reference or review, and we're gonna use the consensus process for a vote on the approval of the meeting summary. Is there any discussion of the February meeting summary or proposed changes?
Wasn't sure if Jody and Greg were on the last meeting. It reflects that they were. I don't know if they checked in after and I missed them, but just to be sure.
Thank you, Lois. I know Greg was.
I do remember Greg.
Yeah, I
There.
was.
Jody was.
And this is Jody. I was as well.
So staff, thank you. Lois, thanks for being the check on that. So they were both here. Any other edits or changes or concerns? All right, is there a motion to approve the minutes? Hello, thank you. Jane, is there a second? Yes.
Second.
Thank you, Eileen. All in favor, say aye.
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 Hi.
Great. Anybody opposed? Okay, the motion is approved. Now, we have, Anything back
I
from?
think we'll have Tom and John and they're on next because I just got a message from Judy saying she is 11 minutes still till touchdown.
Okay, so John and Tom, if you are on, there you are, John, and I see Tom as well. So staff, if you will bring up their presentation. So we are going to go to tab 4. We're shifting the order ever so slightly. Board members under tab 4. You will see the information that is before us. So I will turn it over to you gentlemen to talk about the financial analysis of our Washington hospitals.
Thank you, Director. It's very nice for us to be back presenting on conclusion of our analysis that we presented to this board about doing. We have like the director said, it's a lot of data in this presentation as well, and we want to spend about 15 minutes going through the slides. It's really fast, I'm aware, but please interrupt, ask questions, or we do want to get through it pretty quickly so that we have time for a discussion afterwards. I also want to point out we do have a narrative report that is available very soon. It's been turned into HCA that accompanies these slides with a whole lot more detail and explanation and methodology, et cetera, et cetera. So let's jump into it. Thank you very much for having us. So we're going to cover a bunch of things in 15 minutes. We're going to refresh on the benchmark, review our goals. We set up these goals with our team at HCA that we work with on this board about 1.5 years ago now. We're going to quickly go through our 3-prong approach in reviewing hospitals. We're going to look at how we got down to the 45 hospitals we reviewed, spend a few minutes on each piece of our analyses. There's a kind of a 3-prong approach. We'll get to the conclusion. There's several pieces of appendices that include methodology to some of the calculations and adjustments that we take or make to the data. Thank you. Let's go to the next one. So this is something you're very familiar with. Just to point out, using 2022 data, your cost growth benchmark for Washington is 3.2%. So we're using that as we review hospitals, which comprise of about 35% of total healthcare costs. And as we review hospitals, costs, price, and profits, we want to we want to point out how big of a role hospital costs are in achieving that target of 3.2%. And let's see. Let's go to the next slide. Okay, here are our 2 goals. How does Washington hospital industry compare to the nation on costs, price, and profits? And can we identify individual Washington hospitals that appear to be outliers in cost and price and or profits? And we define outliers as a hospital whose metric has a value greater or less than 10%. All right, let's jump into the next slide. And Tom, please jump in. I don't want to hog the entire 15 minutes. So our 3-prong approach, or 3 steps to our analyses, creates different types of metrics to allow us to review a hospital's costs, hospital's prices. Those are 2 different things. Our data source is the Medicare cost report, among other publicly available pieces of information. A lot of that detail is available in the appendix and or the narrative report. But we first create these high-level metrics on cost, price, and profit. And cost and price are adjusted. What we're doing here is we're looking at other hospitals across the country that appear similar to the Washington hospitals. And we worked out a few techniques in identifying how we can determine a hospital if it's like another or not, with a group of folks from a subcommittee to this board, including a Washington State Hospital Association representative. Our second approach looks at Medicare payment to cost ratios. This, to me and Tom, is kind of an additional cost efficiency measure. We rely and respect all the work that MedPAC puts into setting Medicare reimbursement levels to achieve access for its Medicare beneficiaries. And what we can do with a Medicare cost report is look at Medicare revenues or payments and Medicare costs and create a ratio. And that ratio, if it's 1.0, you're breaking even on Medicare. And if it's less than 1.0, you're losing money on Medicare. And if you're over 1.0, you are turning a little bit of a profit or a margin. We have a Medicare payment to cost ratio in the appendix for each hospital. And we have an assessment on the entire 45 hospitals that we looked at. And then our last review is kind of the pure price or revenue and cost trend. And this is hospital only costs or hospital revenue. These are unadjusted and we compare these to national trends, and we do have some statewide trends as well. We think, these three metrics in sum help give insights to healthcare administrators, folks on this board, and allow you to triangulate an understanding of, is this hospital a high cost hospital? Is it possibly cost inefficient, or is it cost efficient? Is it a high price facility or not? So we don't think there's any one metric or any one data source really that can point out any conclusion of this complex industry. But having three different looks at some of these metrics allows you to start putting together a story.
John, we have a question. John, we have a question.
Yeah, great.
Jane Beyer?
Yeah,
Go ahead.
great.
Hi, John. How are you?
Oh, hi, Jane. Very good. Nice to talk to you again.
It is good. So question, I'm trying to remember which services are captured in these figures. So presumably it would be hospital inpatient. And what for hospital outpatient, is it the facility piece as distinct from professional? Would hospital outpatient be considered physician-owned practices that are billed as hospital outpatient department? How does that work?
Yeah, I think, Tom, better question for you.
Yeah, these analyses encompass everything the hospitals does. It's both inpatient and outpatient. And depending on the numbers we use, it may or may not include cost revenues associated with the physician. You will hear us use the term hospital-only costs. Those are costs that generally Medicare feel are reimbursable, as opposed to the total cost the hospital incurs. So those costs obviously wouldn't include physician related costs. But we also do look at total operating costs, which again encompasses everything, all the costs that the hospital incurs.
The professional, so the 5 categories: inpatient, outpatient, professional, and other. Is that correct, Tom?
On some metrics, it will capture the professional, but it's definitely inpatient and outpatient.
And emergency department, for that matter, sometimes that is thought of as separate. Does that answer your question, Jane?
Yep, thanks.
Okay, great. Okay. All right. Well, and just to point out, I know the board is reviewing cost drivers of healthcare costs, and Tom and I look at a review of the costs of the providers themselves as an additional cost driver analysis. Typically, when somebody says cost driver analysis, it's at the patient level, but it's also important to review how a provider's costs are, and especially when you have an industry that is tax exempt, whose reimbursement is sometimes, at least from the public sector, reimbursements based on based on cost. So we see our analysis as an alternative and a complementary review of cost driver analysis. So let's go to the next slide. So we started with 104 Washington hospitals, and we did a little carve out. We removed hospitals with 25 or fewer beds and hospitals that had incomplete data in the Medicare cost report. That got us down to 62. We removed 17 more hospitals that were either psychiatric, rehab, long-term care, or children's hospitals to get us to the 45 hospitals under this study. Those using 2022 data, those 45 hospitals account for 90% of available beds and about 85% of hospital patient revenue in the state. So you're getting about 5/6 of the business looking at just these 45 hospitals. Let's go to the next one. Oh, and there's a list of those hospitals, city and county in the appendix as well. So our first prong is this peer group comparison. This is where we identify outliers. This is where we adjust each hospital's data to make it look, to make it comparable to other hospitals across the country. We take anywhere between 5 and 20 other hospitals and compare them to the subject Washington hospital. We adjust both costs and revenue. Revenue is adjusted with an acuity metric, and costs are adjusted to account for labor and wage differences on the administrative costs of a hospital, and service costs are adjusted with a COLA, cost of living adjustment, to account for variation of the cost of goods across the country. What we found are that 45 hospitals, the majority of them, 27, and that accounts for about 70% of the revenue, have higher prices than their peers. So these are something we would call high-priced hospitals. 19 of those hospitals, about 40% of the patient revenue or market share, have higher costs than their peers. And 15 hospitals, or about a third of the revenue, are higher than their peers in both price and cost. So these 15, a third of the hospitals we reviewed, and about a third of the revenue of the hospitals we reviewed, have that individual moniker of being a high price, high cost facility. We've arrayed the 45 hospitals and these blue dots here on this kind of scatter plot, where the x-axis or horizontal axis is cost with those adjustments I just spoke of, and on the vertical axis or y-axis is the price. The hash mark at 100% represents the median of all the different peers of each individual hospital. And that little box around the hash mark at 100% and 100% represents the hospitals that are not outliers. And anything outside of that box is an outlier. Now, where the hospital lands in the quadrants here matters. The lower left quadrant, or Q1, is lower than its peers in cost and price. But Q3, or quadrant 3, the red one up in the upper right, these are hospitals that are higher in price and cost than their median, than the median of their peers, and that's where the majority of these hospitals fall in Washington. And you can kind of see a correlation between cost and price if you ran a regression that probably have a pretty good R-square. Okay, let's go to the next slide. A little bit more information on the peer group comparisons. So we reviewed 45 hospitals, 27 of them were high price, 15 of those 27 were also high cost, and several two of the high cost, high price had high profits, and one hospital of the high price had normal costs and a high profit. But here's a little bit more data here. The yellow shaded boxes are hospitals we spent a little more time on in reviewing. Here's a little bit more summary than what we just went through, but 27 hospitals of the 45, or about 70% of the market share, represent hospitals who are considered price outliers, high price. 19 of those, 19 hospitals, 15 of the same, high price hospitals have high costs. And these are more than 10% greater than the median of the peer of that group. There were a few profit outliers, 6 of them, in fact, and there were a couple of hospitals that were found to be high cost and high price and high profit, hitting that trifecta. Not a good thing to hit. So let's there's more details in the appendix on all of these hospitals. Let's go to the next slide. One of our other measures is this Medicare payment to cost ratio. And it's simply Medicare revenue divided by Medicare cost. Source is right out of the Medicare cost report. And if you're a 1.0, where payments equal cost, you're breaking even on Medicare reimbursements. According to MedPAC, in the March 2024 report, a hospital at an efficiently run hospital, they have found to be at about 97% or 0.9 cents. In other words, they're losing about 3% on Medicare business. This is a great measure for us to now compare Washington hospitals and their payment to cost ratios to this median, or what MedPAC, not necessarily a median, but what MedPAC has said as what an efficient hospital should be able to attain from Medicare payments. If you're below the 97% mark, according to the MedPAC report, you're deemed to be an inefficient hospital. We found that 39 of the 45 hospitals had a Medicare payment to cost ratio below 95%, and the state median is about 83%. So quite a bit lower than what MedPAC has stated as what an efficient hospital should have. And I'm ready to go to the next slide. Thank you. Here's a little bit more detail from that metric. The point being, there's a lot more detail in the narrative report, and Appendix B has a breakout and a ratio with the hospital name for each facility. In fact, there's a few Washington hospitals that are 1.0 or higher, where they're actually making a profit on Medicare reimbursement. Go to the next slide.
John,
Yes.
did MedPAC trend this over time on this inefficiency metric?
What they do a review every year, and so they're not projecting. So, for example, the MedPAC March 2024 report, which just came out a couple months ago, is reporting out on metrics with data through 2022. So just like our analysis, and which we'll spend a little bit more time on in this next section, our data goes through 2022. So they're using data through 2022, and they've found that an efficiently run hospital in 2022 should lose about 3% on Medicare business. And that's actually a reduction from 2021. In 2021, that number was closer to 100% or 1.0 or 99. They were in breaking even or losing 1% in the prior year data.
Thank you for that. And then my other question was, does MedPAC opine about health system consolidation vis-a-vis this ranking?
Well, the MedPAC report, so MedPAC, very nonpartisan congressional body, basically doesn't opine. What they opine on is
wrong choice of words.
Yeah, they review about 15 different provider types, one of them hospitals, and report out, and it's really for their Medicare to determine if their reimbursements are high enough to meet the Medicare access threshold, and it's really targeted about Medicare. But what we found, as Tom and I review hospitals across the country and several other states, is that it's an indicator of how a hospital's efficiency with other payers as well. If you're inefficient on Medicare reimbursement, you tend to be inefficient on Medicaid reimbursement, and therefore require a higher commercial reimbursement amount to break even or generate a margin. And conversely the same. If we see hospitals that are efficiently run or have a good Medicare payment to cost ratio, like a 1.0 or greater, we found them to also be efficient with Medicaid and commercial reimbursements as well.
Thank you for that. Eileen's got a question.
So since our state average or the median is median is 83%, how does that compare to the rest of the country, the other states? Are we, have more that are, or I guess, are we lower than everybody else? Or where do we fall?
Do we have a national number? Yeah.
No, I don't have a national number handy. I can say, unfortunately, 83% probably is not unusual. I think there are a lot of hospitals across the country and maybe even in states that may be in the same situation. However, you look at the individual hospitals, as John mentioned, you're going to see payment to cost ratios, in the 60s and 70s, all the way up to the one teens, if not even more. So the question becomes this: if you're an 83% hospital, what is causing you to be there as opposed to being closer to break even?
Great, thank you.
And
Margaret's got a question for you, Tom.
Yes, I'm wondering if some of the committees have reviewed this report and what kind of feedback you've gotten on the methodology that you've used, whether particularly the hospital representatives or the hospital association representatives are comfortable with this approach.
Well, I'll start, Tom, and please add in anything I miss. But this is a brand new report. The narrative report was just delivered this week, late last week, to HCA. I don't believe WSHA has had a chance to review the narrative report. I can say that they had input into the peer grouping analysis that we met with them a little over a year ago now, with others from the data subcommittee to this board, and developed the metrics or a process to identify like hospitals. It's a 4-prong approach in detail in the narrative report. I don't think you're asking for the detail of that, but you're just asking, have they reviewed it? When they review it, they're not going to like what they see. It shows that many of Washington hospitals are high price and high cost. They will not like that pointed out. I know there's a variety of different information coming out about Washington. I think last month you heard from Jeb Shepard saying that Washington was number 3 in cost affordability. I don't think that gets to the point that we're trying to make, though. So I don't think we're contradicting that finding. That affordability is more of a measure of, the health status of Washingtonians, and you're healthier than average, and therefore your costs are a little lower, among other metrics. What we're reviewing is how this hospital industry does business. And what we're measuring are costs that business decisions were made a long time ago, maybe a decade, maybe 2 decades ago. We're seeing the ramifications of that.
I will point out that this particular analysis, I'm sorry, the one we were just speaking to, the payment to cost ratio, is a pretty common metric that various entities look at to determine the efficiency of a hospital. We know that RAND has a calculation that they do called Medicare margin, which is similar to this. And we've spoken to hospitals in meetings with some of our other clients where they too take a look at this and try to determine for their own purposes how efficient they may be performing.
Thank you.
Also has his hand raised.
Edwin, I think you've got a question. Go ahead.
Thank you. Just want to follow up on the methodology question. And I just apologize if it's in here because there's a lot of detail, but I was wondering if you could kind of succinctly summarize how are you calculating price and how you're calculating cost? Because I didn't quite catch this in those slides. And I think it's particularly important because those are the two key inputs to your metrics.
Sure. When we look at price and cost in the pure benchmarking analysis, we're talking about price per patient and cost per patient. And when we talk about per patient, we're talking both about inpatient and outpatients. There is a industry standard volume metric called adjusted discharges. And what that does is it equates outpatient activity to inpatient discharges so that you capture both the inpatient and outpatient volume. You divide that into net patient revenue, then you come up with a price per patient, and that is our price metric. On the cost side, we use what we call hospital-only costs. These are costs that generally Medicare considers reimbursable, and they do not include any costs associated with residents and interns, because that can significantly cause significant differences between hospitals depending on how intensive their teaching activities are. So we use these hospital-only costs and divide them by adjusted discharge to come up with a cost per patient, and that is our cost metric.
Okay, I appreciate the detail. And I think the one thing I'm having trouble reconciling is, at least my understanding with some of these Medicare reimbursements, because this seems like it's largely driven by reimbursements, particularly the price piece, that I'm trying to understand a bit how that varies by hospital, because I think my understanding, correct me if I'm wrong here, is that these are largely standardized with some adjustments for teaching status, with some adjustments for percent of, I think, charity care provided, some adjustments. So at least I thought my understanding was these are relatively standardized.
Yeah, on a prospective payment system hospitals, which are essentially the hospitals that we're looking at, they do start with a standard, for instance, inpatient rate. However, there are adjustments, as you mentioned, made for various things, including the intensity of the services performed for the patient, geographic location. They get adjustments for that. They get adjustments for teaching intensity. And so for that reason, when we look at the Medicare payment to cost ratio, we look at Medicare reimbursement as taking into account a lot of those things that may make a hospital different. It more or less neutralizes those geographic differences, those teaching differences, those acuity differences. And that's why we use that as part of our efficiency analysis with respect to looking at those costs, Medicare costs compared to the Medicare payments.
Okay, so I think there's probably a lot of, I think maybe the answers these are in some of the technical detail, and I think it sounds like there's a more broader report I can look at that might answer some of my questions, and maybe I'll follow up with you after I look at that some more.
Certainly.
Just a reminder, we did a methodology presentation a while back. I can send you the link to the methodology presentation. That would have been a couple of months ago in the process. I can also send you the links to where they presented at the advisory committees.
No, that'd be appreciated. Thank you.
Of course.
One thing to point out is when we say price, we're talking about the entire payer, all payers. This is an all revenue number. When we're looking at just Medicare payment to cost ratios, we're only looking at Medicare revenues, Medicare costs. So I wouldn't want you to conflate when we say price to anything to do with that Medicare payment to cost ratio. That's Medicare specific. And what we do is we use it as an indicator of cost efficiency because of the things we found that hospitals, if they're efficient in Medicare or inefficient in Medicare, they're similarly efficient or inefficient in Medicaid. And that has an impact on commercial pricing or costs. Certainly. I don't know. Okay. So this next set of analysis is looking at revenues. Thank you for advancing the slide. Is looking at revenues and looking at costs. We're looking at whole dollar revenues and revenues per adjusted discharge, or PAD. Those are the columns in blue. We're comparing all of the 45 hospitals' trends using a compound annual growth rate formula. We're looking at also two time frames. We're looking at an 11-year data set and a 5-year data set. The 5-year data set takes us to as current as we can get with 2022 data and looks back to a couple of years before the pandemic. And then our 11-year data set goes back to 2012. Here are your national versus Washington trends for whole dollar revenue and whole dollar per adjusted discharge, or PAD. And in the pink or light red shaded columns are cost. The first column, the top table is the whole dollar cost for the two time frames, the 11-year data set, the 5-year data set, and then the cost per adjusted discharge are down below with those two time frames. You can see Washington is doing better or lower trends as compared to the nation in a couple of the categories we have here, but also a little bit higher than the nation in a few of the categories. For example, in your pricing, if you're looking at costs, you're doing a little bit better than the nation in terms of the short whole dollar CAGR, or whole dollar cost compound annual growth rate of 5.94 versus the nation at 6.68. However, your trends on the other cost categories are mostly higher than the nation trend. On the revenue side, lower than the national trend, pretty similar in some of these categories. And what we've done is we've compared individual Washington hospitals to the national trend and highlighted where the individual Washington hospital exceeds the national trend. And just for reference, we have at the top there that your cost growth benchmark for 2022 is 3.2%. So let's look at a couple of examples of hospitals that we have on the next slide. Now we wanted to, since there's a variety of hospitals in that group of 45 that are from small to large, we wanted to assess only the larger facilities. So we used 1.9% of net patient revenue as a measure to kind of put you in the category of the ones we reviewed, or being sizable enough in the market share. We found that number to be pretty useful because using 1.9% or greater, we found 23 hospitals of the 45, and they represented about 83% of the entire market. The other half of the hospitals, 22 hospitals, had less than 1.9%. In fact, they had less than 1.5%, and they comprised of only about 17% of the market. So we're going to review these 23 hospitals who have a market share of greater than 1.9%. Now, we've done a bunch of different considerations here. So the top 3 rows are hospitals looking at their trends as compared to the nation on either the 11-year or the 5-year trend. And we marked them if they exceeded in the whole dollar cost, the whole dollar revenue, or both. And we found 16 hospitals to be exceeding the national trend in whole dollar costs, 14 hospitals in whole dollar revenue. And those same 14 hospitals also had whole dollar costs, high trends. These represent a little bit more than half of the market. And then we brought in peer group benchmarking information from the first prong of our analysis and listed the number of hospitals that had a high trend and also either a high price peer group comparison or high cost hospital from the peer group comparison or high price and high cost. It's a lot of information right there. These lists of 16, 14, and 14 can be found in the appendix in tables 1 through 3. The middle block of hospitals are looking at not whole dollar trends, but dollars per adjusted discharge, whether it's a revenue dollar or a cost dollar. So the first line in the middle bracket, where there are 17 hospitals, these 17 hospitals exceeded the national trend in either or both the 11-year and 5-year national trend figure. They comprise of about 57% of the market share. Several of those 17 were also high price. 8 of them were high cost. In the next category, we have hospitals who exceeded the per patient revenue trend. There's 19 hospitals in that group, about 63% of the market share. 14 of those hospitals also had a high price outlier marker from the first set of analysis. So what you're seeing is there's a lot of overlap of hospitals from this set of analysis to the peer group benchmarking analysis in our first prong or first approach. In the last bracket, you'll see group of hospitals that are exceeding the national trend in both whole dollar and per patient costs. There's 10 of those, or exceeding the national trend in both whole dollar and per patient revenue. There's 10 of those, but it is just slightly different 10 hospitals. And you'll see 7 of them are price outliers from the first prong analysis, and about half of them are high cost and or high price and high cost. We have these lists in this slide deck, and we're going to get to them. And then that last category where there's 8 hospitals, these are, you've exceeded the national trend in all of the categories, whole dollar and per patient, cost and revenue. It's about a quarter of the market share for those 8. We're going to go look at that list. So let's look at the first list. These are hospitals. Yeah,
I think what we should do is kind of move into the conclusion section to roll this. Since that just
great idea, Director. It's a great idea. Great idea. So the problem with going
of these slides.
Yeah. Well, you'll see some names that repeat, and we have so these 3 lists. And you'll see a lot of similar names across the different lists. And so to me, this indicates you have hospitals that are exceeding national trends consistently, and also in a comparison to their peers across the country are also high cost or high price in some categories. And then we have additional 6 lists in the appendix, and you'll see just a lot of recurring names. And if there were a place for you to start understanding or wanting to have a discussion with these hospitals, this could be a roadmap to that. So let's just, as Director Birch mentioned, let's just jump to the next slide. So what, right? What we found is comparing Washington hospitals to their peers, we found that hospital costs are a significant driver of the prices that hospitals charge. And we found that higher prices negatively impact, of course, public and commercial payers. And there's a significant amount of hospitals business in the state that generate higher per patient revenue and per patient costs as compared to their peers. Yes? I'm sorry, was that a,
No, that was a cough.
sorry. I don't have a camera of you, so I can't tell. We found a large share of hospitals with a Medicare payment to cost ratio of 95% or less. The median 83%, as we've talked about and spent a bit of time on. We know hospitals, we know that you know that hospitals contribute significantly to healthcare cost trends, that they represent a majority of the state's hospital industry there and that are experiencing price and or cost trends that exceed the national trend. Therefore, we think meeting the cost growth benchmark may be in jeopardy if these price trends exceed those targeted increases. And this current financial condition of hospitals that we're seeing, data through 2022, this is the result of strategic decisions made a long time ago. Altering the direction of the hospital industry, even if efforts start today, this is a long-term endeavor, and we encourage you to do so. So thank you very much from both of us for allowing us the time, and I hope I didn't go too far over.
So I think, thank you for that, John. And I know the board, since we just received this, I think Tuesday, the report came in Monday night. I know the board needs some time to digest and cross-reference some of the lists and the appendices, but are there any final questions? Oh, Bianca's got her hand up. Go ahead.
Yes, thank you for the great presentation. Definitely lots to digest. And while I know there were discussions prior about some methodology, it's still a lot to unpack. I'm curious about a couple things. One is whether you've had a chance to look at specifically what happened to cost growth during the pandemic. I know you use these longer 11-year versus 5-year time frames, but were you able to actually maybe take out the years of COVID just to even see what path different facilities were on? And related to that, I know cost includes cost of labor, and it's only really based on wages, and I'm not a specialist in the wage index from CMS, but it's mostly based on, I believe, employed labor rather than contract labor. So how is contract labor accounted for in some of the cost growth around labor?
I'll take the second question first. When we look at the cost for the hospital, we try to determine which percentage of those costs is labor. There is enough information in the cost report to tell what the contract labor piece is. So as we accumulate labor costs, it does include salaries of employees and any salary related costs for those employees, and also contract labor, both administrative and frontline patient care contract labor.
Are you able to provide that breakdown?
It's not in the report, but we can certainly show by hospital what percentage of their total costs came out to be labor, and including contract labor, if that's useful.
Bianca, I was recently on a NASHP call with our friends at the Washington Health Alliance, and Marilyn Bartlett was reporting, based off national Medicare cost reports, that the direct care costs off of hospital cost reports are at 31%. They were going to get more definitive. There's a huge bucket of other labor costs, and then there's admin costs. So I would ask John and Tom for future presentations to just delve a little deeper with our NASHP partners on that issue. I see Margaret's hand up, and then here in the room I have Ingrid. So Margaret, you're next.
Thank you. I'm really struggling with trying to understand what's different about Washington that we should be seeing these results. And you mentioned that there were decisions made maybe 10 years ago that would impact this, but I suspect that hospitals in other states were also making decisions 10 years ago. So could you summarize what you think is causing the Washington hospitals to appear to be less efficient? And having been on a hospital board, I know how hard they're trying, and there are a lot of smart people there. So it's not really making a whole lot of sense to me yet in terms of figuring out what the drivers are.
Sure. You know, obviously every hospital's got its own challenges with costs and you know, how they can be more efficient and we're not suggesting they're not trying and they're not trying hard. I always said through my career as part of the large hospital system, it was 100 times easier to find more revenue than it was to get rid of costs.
Yeah.
This is you know what I'm about to say is anecdotal. I don't have real strong data to back it up, but we do see directional that if hospital commands higher prices, they grow into those prices. If they have the market power to bring in higher prices for their services from their commercial payers, generally their costs are allowed to grow into that pricing. So market power may have a big play into the cost levels at these hospitals.
Thank you.
Ingrid?
Thank you, Sue. Thank you, John and Tom. My head's spinning a bit, but super helpful, a lot to digest. Two things. One, your presentation is leaving me curious about the grouping of hospitals that you found to be efficient by your definition, low cost, low price, presumably having a normal profit margin, and what we can learn from how they're operating. So that's just, I want to put a pin in that. So it's sort of the flip of focusing on the ones with the higher everything. And then also thinking of this report in relation to two other hospital price transparency reports that have recently come out, and just striking how it all is pointing in the same direction. So thinking about the Washington Health Alliance, a report issued last week, they're using different ways to do the rating, but on price, showing that on average, Washington hospital prices are 288% above what Medicare pays. And then also the RAND 5.0 released on Monday, showing Washington hospital prices 252% of what Medicare pays. So there's different ways to slice it and dice it, but really what's directionally the same.
Right.
Thank you.
Right.
John, we need to move on to primary care, but I'm just wondering in closing, if you or Tom were to offer this board, so your thoughts about solutions or next steps, what would they be? For some of our policy lever discussions, is there anything you want to share?
Sure, I won't take too long, and Tom, please chime in. But you know, when we look at national rankings and how Washington compares nationally, we see you in the top 8 for price per adjusted discharge, and that's an adjusted price. We see you in the top 10 in cost per adjusted discharge. This is the same situation we found Colorado to be in a number of years ago. What Colorado's done is each year this data comes out, they do analysis such as what Tom and I have just presented, and they meet with each hospital system and talk through the data and talk about it and ask questions. And not only focusing on the inefficient ones, to Ingrid's point, also talking to the efficient hospitals. When that project started, Colorado was in the top 10 of price, cost, and also profit. Their rankings have dropped. I don't know if it's due to this analysis coming out every year and holding the hospital in an attempt to hold hospitals more accountable or not, but they're no longer in the top 10 in price and cost. They might be right on the cusp of one of those. Tom can correct me, but I think with data and with the numerous access points of transparency from what Washington Health Alliance has done, creating interesting metrics using your APCD, other metrics, using that federal pricing transparency data, bringing all this to light and discussing it with hospitals might have a good effect on the decisions they're making today, which we can then see in the future. So to the point you made, that we're looking in a rear view mirror of decisions made long ago, and we're seeing the cost trends are higher as a result of that. It's time to start the conversation and begin to hold this industry more accountable. Tom, sorry if I took too long. but
I think, yeah, I think you hit the nail on the head.
Thank you both for this information.
you.
Board members, it's not the last time we will be reviewing this again, another data slice, and we have other reports before us today. So I'm going to move us to our next topic. Thank you, Tom and John. All right, I believe we have Dr. Judy Zerzantal, our chair of our primary care committee. Her presentation is under tab 3, and she is not here in the room, but I'm assuming we're opening up the phone.
I'm online. Yes, I'm on the phone.
Judy,
So hello.
go ahead.
Okay. Hello, everybody. I'm excited to be here. I wanted to give you a preview of what will be coming towards you the next meeting. So if I can go to the next slide. I wanted to remind you of where the primary care committee has been focused to get to that 12% primary care spend that the legislature gave us. Today, I'm going to share with you 7 strategies that the committee has come up with. We're still discussing those strategies, but very soon we're going to prioritize them, and we're going to bring 2 or 3 to you to approve and move forward in the legislative report. So, but I'm going to give you a preview today of all 7 strategies so you can get a sense of our work and ask any questions that you might want to. So this graphic shows used to define and look at primary care expenditure. So starting with direct investment, which is the one that most people think of first, is paying more money for primary care services. The second quadrant, if you go around in a clockwise fashion, is capacity growth. So this is things like reducing administrative burden, so there can be more time spent on patient care, and investing in workforce and expanding that workforce. The third quadrant is patient behavior or patient engagement. So increasing people's awareness of the benefits of primary care and encouraging them to use more primary care services than other services. And that is sort of tied to the last quadrant, which is reduced expenditure on other services. So maybe there's less spending in the hospitals, there's less spending on ER, on specialists, because a primary care provider is providing that. So next slide. These are the 4 principles that we use to figure out these 7 strategies and develop them through a number of meetings and conversation. So we decided that any strategy or recommendation should adhere to these principles. So first, there should be a very clear link between the policy and achieving the 12% primary care expenditure target. Second, that it should be a very clearly defined action, not a vague action. Some of these could be a little vague, but we have been working on specificity of exactly what it means. Third, that policies are financially, operationally, and politically feasible. And then fourth, the policies result in improved access and improved quality, not just expenditure on primary care services, so that ideally you're getting to better patient health outcomes. So the next slide is my last slide, and these are the 7 strategies that we are considering and that we will bring to you the next time that I talk. So the first one is fairly straightforward. It's the increasing primary care expenditure as a percentage of total healthcare spending. And underpinning this one is setting some concrete goals to have the legislature take action to mandate both commercial and public payers to increase primary care expenditures by 1% a year until the 12% is met. Currently, we've been talking with OIC, the Office of the Insurance Commissioner. They are looking at ways that they can leverage some of their current authority to do some of this. So those are some of the pieces in process. The second policy is to increase Medicaid reimbursement for primary care. There has been some talk around the legislature about this one, but it is essentially increasing Medicaid payment for primary care to Medicare rates. So to be at least 100% of Medicare rates. The third policy is multi-payer alignment. So I think many of you know the multi-payer collaborative here in Washington has been working on aligning standards, quality measures, practice supports, and payment methodologies to support primary care. And recently we have been identified as a Making Care Primary State, which is an initiative from the Center for Medicare and Medicaid Innovation Center. We are working on linking those two programs together. And this would be an action that the legislature would encourage more advancement in these multi-payer primary care alignment efforts. The fourth one is patient engagement policy. So that there would be some sort of standard set of supports for both payers and purchasers or employers to use to promote people's use of primary care incentives and accessing preventive services. So this could be things like mandating a PCP assignment. It could be health fairs. It could be public health folks educating about the importance of primary care, but working on patient engagement for this. The fifth recommendation is about workforce, and this one is pretty easy, that we would support the workforce initiatives that have been identified through the Health Workforce Council and work on that collaboration. The sixth recommendation is to use value-based purchasing or alternative payment methodologies to make that investment in primary care. And so using the Healthcare Payment Learning and Action Network framework, that any additional investment in primary care would be tied to an alternative payment methodology to count towards that expenditure goal. And then the seventh one is an interesting one. This came from conversations with Rhode Island and Oregon when we asked them what they wish they knew when they started this process. Both of them gave this recommendation that instead of identifying a primary care expenditure target that's based on a percentage and a per capita, that instead of having an aggregate expenditure ratio of 12%, to create targets that are based on a per capita expenditure, so like a per member per month increase. This would insulate primary care if there are ever decreases in cost expenditure on other categories, and would also ensure that that primary care spending is really going up at the ground level. So those are our plans. We have another meeting later this month, and then one in June that we're going to finish discussing these. We have a couple more of these strategies to discuss in depth, and then we're going to bring a prioritized recommendation to you at an upcoming meeting this summer. Are there any questions?
Great, Judy, thank you. Jane has a question.
Thanks, Judy, for the
Yes.
great work. So question for you, I'm looking at number 3 and number 6 together. And one of the big issues that we've heard about in terms of trying to increase use of alternative payment methodologies is, I'm a primary care doc. I have contracts with 15 different carriers and or self-funded health plans, and I have 15 different APMs, each of which is doing something different. So I mean, one concern I have about seeing something where you're tying the ability to count the increased expenditures toward pairing it with an APM is, are we going to end up making it worse for primary care providers in terms of pressure to enter into APM arrangements unless we can make number 3 work? And you got some sort of a multi-payer approach. Anything, so that's number one. And number two, to bring back to the board, and I should do this work myself, but really having an overall understanding of where CPC Plus and the other APMs for primary care services, what are the results of the evaluations of CMMI's work? And are they reducing costs? Are they improving quality? Before you make a commitment to say, yes, let's use more APMs for primary care. So those are two thoughts.
Thank you,
Great.
Jane.
Yeah, thanks, Jane. So number 6, that's on our docket to be talked about in our next meeting in a couple of weeks. So I couldn't tell you, although I do know that most of the APMs that we have, at least that the MCOs have as an example in Medicaid, are really all on primary care. And so I think being careful and being thoughtful about, if we were to say this is the only way, I agree with you. It should be in a way that decreases administrative burden rather than increases it. We have looked at some of the CPC evaluation and other primary care first that CMMI has done. It's interesting. Probably the best evidence is when there is a primary care provider-led accountable care organization with primary care underneath of it, that really gets to both better patient outcomes in terms of quality measures and also some cost savings. So there's a piece of that, and how to move those levers. Some of those levers are more local than what we can control, but I'd be happy to chat with you more either offline or here about more of the results of those evaluations.
Thanks.
Judy, this is Sue. Real quick follow-up question. On your recommendation about the Health Workforce Council, are they looking at, are there any recommendations about requiring GME to be used more for primary care and psychiatry versus my understanding that we have our GME heavily moving towards specialty workforce? Is there any recommendation off the workforce council not revisiting GME?
I don't remember. That was the first recommendation that we talked about in January, and I don't remember the specifics. I don't have them in front of me, but I can check that and get back to you. I know that we have talked about that in other circles, but I'm not sure if the council has made those recommendations or not.
Thank you. Other questions? All right. We thank you, Judy. I know you'll.
Thanks.
This issue is gonna just keep percolating. What I'd like to do now is, I know we're gonna be off a little on our break, but Janine, I'm wondering if we could ask Janine Smith from HMA, Liz is here in the room, sorry, for Janine to present and lead the discussion on our first strategic lever examination, the business oversight, including mergers and acquisitions, private equity investments, and provider ownership and closures. And then we will move to a quick break. Liz and I mean, can we adjust? Can we do that? Yep.
Hi, I'm Dr. Janine Smith. I'm in the Portland HMA office down here in Oregon, and it's a pleasure to talk with you guys today. I know this is a a lot of information meeting, so I'll try to make this smooth as I can. I was asked to kind of give you an overview on this, what we kind of are combining together. Business oversight includes mergers and acquisitions, private equity investments, and provider ownership and closure. Next slide. It's part of your overall strategies that you're going to be considering. Next slide. And then, of course, there'll be other strategies and policies under consideration, and this is a listing that to incorporate in other policy options. So we'll move on to the next slide. So business oversight, why do we care? All of these activities can contribute to consolidation in the healthcare marketplace. Just as you were hearing from Tom and John there, market power can be a big factor in terms of rising prices. So it can increase their leverage in negotiations in any contracts with health plans. It can lead to higher prices and ultimately result in elevated premiums for consumers. And it can have a mixed effect on access to care. There's lots of different types of integration or efforts that can lead to that consolidation. I have listed a few here, sort of horizontally. Hospitals, for example, hospitals joining together. Vertical integration, where hospitals might buy practices or others along the supply chain. Cross-sector, they might come from out of healthcare and start to partner or be part of other aspects of healthcare. Private equity, where you pool funds from investors to invest in industry. And then closures, which we know have big impacts in both my state and yours in the rural practices and hospital areas. And then there are sort of soft consolidations, things like where people come together, sort of have clinically integrated networks in order to try to do more collaborative care, such as the accountable care organizations. Washington State already has a significant degree of consolidation and integration, but these activities may continue, and something for you all to consider is how you might want to address them. Next slide. So there's a couple of approaches that have done across the country on some of these, on how to address this. Notice and review is that you would have a required notification to an entity based on some criteria. Often it's usually the larger financial valued entities or larger dollar creating entities that would really have a significant impact, and then have it be analyzed and reviewed. Some will go even a step further and do notice, review, and approval, or have some say in whether this merger or acquisition could proceed. Currently in Washington State, the state AG would need to go to court to oppose a merger, and mostly reviews larger mergers. There are some downsides where some mergers could potentially reduce necessary partnerships for preserving access to care. This has happened in Oregon recently, where a large entity was took over a clinic that was about to have to close its doors. And also consolidation might lead to some regionalization of services, which might improve quality by having a higher volume, being more consolidated in a specific facility, and could maybe even also lead to enhanced care coordination, which could improve value. The Federal Trade Commission, the FTC, and the Department of Justice, both are starting to take a bigger look at merger and have replaced their fairly outdated previous guidelines from 2010 just recently in December. And they have some guidance now for how you might want to consider how you look at mergers and acquisitions. Next slide. Private equity is a whole nother, is a sort of a similar, it's just the funding and who's investing is somewhat different. But the funders in this case are really trying to get a return on investment for the investors. There are, at least based on some of the reporting you already have, there's 97 healthcare acquisitions in Washington State in the last 10 years by private equity firms. A lot of times the focus is on physician staffing companies, such as those in anesthesia, emergency medicine, post-acute care, in addition to some other specialties. I know in Oregon, dermatology is a big one as well. But oftentimes they might be the hospitalist that is staffing your hospital, and having just gone to the hospital last week, unfortunately being admitted for a couple days, it was fascinating to be on the inside and watch all this, certainly as a physician for sure. Corporate buyers have also come into the market, such as CVS, Amazon, and then United Health is a huge corporation, as you all well know. So some of the approaches here is mergers and acquisitions. You could require a notice and review to monitor those trends, or you could have a notice, a review, and approve private equity transactions, just like we were talking about a minute ago for overall mergers. And then you could even consider what happens in hospital when it goes from a nonprofit to profit right now, is that they often require a community benefit. And so is there some way that you might want to tie that in to, if you're transitioning from a nonprofit to a private equity owned company, that would maybe then feed back some dollars to the community rather than just to the investors.
Janine, this is Jody Joyce. I have a question about the M&A activity. I put it into chat, but I think the biggest risks to healthcare are not horizontal M&A, but vertical integration. And so is that included in oversight?
Yes. Yeah, well, it depends on how that's set up in terms of dollar. Often when you look at other states, it's the dollar amount of the transaction that triggers whether you have to report it or not. And so where you set that. So if it isn't defined that it has to be vertical or horizontal. It's really more the dollar amount, one entity is acquiring another, and where do you set that at?
Okay, thank you. I'll just say that I think that sometimes mergers are a way to rescue struggling hospitals or clinics or other. And so I think that setting parameters needs to be thoughtfully done to not prevent that kind of activity. But if it's to gain additional market power, then that's where the risks are, because that's what can drive prices and costs. So anyway,
and also how you do it. It may be that the preliminary review is that this absolutely has to happen, and that one I gave an example of here in Oregon, it kind of had an emergency approval based on the financial situations going on in that particular instance, and the loss of the impact to patients was so great that they had to kind of approve something that maybe if it had been different situation of two viable entities coming together, it wouldn't have gone through. Next slide. So these are just a diagram. It's from your report of kind of where the private equity acquisitions are: physical therapy, hospice, behavioral health, optometry, ophthalmology are some of the highest ones. Next slide. And then provider ownership and closure. Just from reviewing your recent reports, what's one of the biggest challenges, and I know from my 15 years in state government down here with the Oregon Health Authority, that was the biggest thing in the world, was trying to understand who owned what, and how could you even do a survey for that matter, because you didn't know where the connections were. And some of the closures and reductions in services are another aspect of this, there have been hospitals across the country and also in Oregon recently, is closing their labor and delivery services or their emergency services, and they may not be reviewed by the AG or don't always require a prior notice, depending on how your state is set up. And so this could also, knowing who owns whom and what the corporate structure is, could really improve your identification of trends and consolidation across the healthcare markets. So a potential approach to this is a comprehensive and transparent database with notice and review that would require, again, you'd have to set the parameters of who would have to report. You wouldn't necessarily, do you really have to have every small 1 or 2 provider small practices do it? Probably not, but some of the larger practices and hospitals, etc., you probably would include into having some requirement, including private equity firms. So you really get an understanding of who owns them, what other health entities do they own, and the number and types of healthcare. This has been well demonstrated in Massachusetts. They've been doing this. They rolled it out slowly, but have some very impressive reporting on using it for oversight and doing a lot of investigation of their marketplace based off of this. They've tried to even combine the reporting requirements with those who have to report to their all payer, all claims database, so that it's streamlined and not overly administratively burdensome to the required reporting entities. In Washington, you would need to understand what is already being collected, where it's being collected, what are they doing at the Department of Health versus the corporate ownership practice of medicine, Medicaid, other agencies. How could you start to streamline potentially and also have benefit of using that information. Next slide. So this is an overview that the Milbank Fund put together that talks about that there are some states that are doing just notice and review, and that's the upper 2 rows. Some are doing it just for nonprofit. Some are doing it for profit as well as nonprofit. The ones in bold, which includes Washington, have authority for more than just hospitals. Those that aren't bolded are mostly just doing it for hospitals and potentially nursing homes through their certificate of need programs. There is in Massachusetts and California, they have, just for notice and review, have set up a healthcare market oversight entity, in addition to the responsibilities of the Department of Health and their AG authority. For the next set are those who can approve with conditions, or disapprove. Sometimes that is in the authority is housed at the AG, Attorney General. And in Oregon, as you've heard from Sarah Bartleman when she was talking to you a couple meetings ago, it's actually a cost board, much like yourselves, but they can actually approve or approve with conditions or disapprove. States like Massachusetts will monitor all of that, and then they are feeding it back, making recommendations back to the Attorney General to actually pursue something, or possibly their Department of Health through their Health Policy Commission. Next slide. So New York, as another additional enhancement to this, is they passed a law just a couple years ago, but right during COVID, so they're just starting to roll it out, requiring a health equity assessment to be filed with the Certificate of Need program for any merger, acquisition, closure, or substantial change in hospital service. The Oregon set up its market oversight program. We were also stalled a little bit by COVID and just really now in the full reporting phase of this. But there have been notices filed. There have been some determinations where it was not necessary to be reviewed. There were some that had a preliminary review and nothing further was done. Some have had more comprehensive reviews, and some have even gotten to the point where they're starting to follow up on them to see if what they were hoping would happen happened and no adverse impact had occurred. There has been public comment associated with all of those reviews. The recent emergency decision to allow that merger was to prevent significant access issues, but it was has been of concern for even legislators to step in to make sure that that closure is or a merger is not impacting care in that region. And then 2024, the rest of the year, they will be continuing to conduct 1- and 2-year follow-ups. The legislation allows them to continue to monitor up to 10 years because you also want to continue to see what happens over time and whether any behavior would be of concern as the merger proceeds. California, their outside entity is called the Office of Healthcare Affordability, and they're also analyzing these transactions. However, they don't have the authority to stop them, but they refer to the AG for enforcement. Next slide. So consumers, there's been some studies and some analysis collectively across studies that consolidation creates less competition. That leads to higher costs. This increased costs can translate down to the patients as well as the payers. And whether it impacts quality is a little bit uncertain, at least in the current studies. And there can be concerns even when there's mergers that are not in the same market. So you have that vertical integration, but it's actually can be like from one part of the state to another. We know that there is an association between consolidation with rural hospital closures and service eliminations, but not a lot of research has been done there. It really can limit consumer and patient options, especially in the rural area, due to lack of services, or can make available care unaffordable. That's what when the closure of the labor and delivery of one of our more rurally outside of the Portland metro area hospital, there was a great concern because it was where a lot of folks from even more rural could get to the hospital in time, and now we're going to have to drive all the way into Portland. It can lead to lower wages sometimes as well. There's been some findings about that, such as nurses, but it's still a little unclear. So one thing about having better reporting and analysis about this is that you as a state can identify areas of consolidation in hotspot regions that might need more regulation to ensure there's less of an impact on the consumer. And you can potentially stop or limit the impact of these business activities. Next slide. So as a potential policies you might want to consider, do you enhance what you currently are doing for business oversight and really strengthen enforcement? So this could be done in a variety of ways. One would be to expand the review and approval authority of the Attorney General. And could they do things without a court order, which is what they usually is their main means of enforcement? You could also give authority to additional oversight entities. That could be expanding the current authority within the Department of Health, or it could be creating a separate entity to do this. Sometimes that is the benefit of that is that oftentimes if it's the Attorney General is having to look at all industries, but by having a more health-focused agency or entity to look at it, it brings in perhaps a more comprehensive look at the impact from a healthcare perspective specifically. And then augmenting that with a comprehensive and transparent provider business ownership and closure reporting process, because to try to really understand what the impact, what is going on out in your marketplace more specifically. The other approach, they're not mutually exclusive, is, how do you try to in some ways discourage consolidation? How can you increase competition or preempt consolidation by reducing incentives for providers to consolidate? Some look at that as maybe site neutral payment might be a step for that. I know we're going to talk about fees here in a little bit. And anything that would reduce administrative burden, so providers would not think that they need to have a hospital buy them in order to be able to survive all the administrative burdens that they face. Increasing price transparency. We know that people can't shop for emergency room visits and emerging care, but it can maybe potentially help for those will help for those that where there is a elective or can make a decision on where they want to go. It also helps them in deciding, perhaps which health plan which network they can access when they choose their health plans. And then allowing more providers to enter the market by looking at, are you restricting anything in terms of competition in how you currently are doing certificate of need, how you currently are doing corporate ownership, practice of medicine, and any scope of practice laws. So this, excuse me. So some next steps would be to decide what you might, and you need to think about which, how you would use your committees to do this. Is what would you do to enhance business oversight? Would you give additional authority for the AG? Would you add additional authority to an existing or future state entity? Would any of those have approval authority? And then what kind of review criteria would you assess them? So looking at most of them of the other programs are looking at access, quality, just starting to look at equity and workforce. And then how would you actually do it? How would it function? What's the time frame? How would you monitor and ensure compliance? And then what reporting do you have now compared to what you need in terms of a more comprehensive and transparent database? And then how would whichever entities you increase their review and potentially approval authority, how would they all work together so they're not duplicating and making it really difficult for the healthcare delivery system? And then looking at potentially enhancing anything that might be in the way of prohibiting competition or preempting consolidation, and those are listed there. Anything that might need to be adjusted or any potential for better price transparency or lowering any barriers. So I'll stop there as far as my talk, and really, it's now really for you all to kind of think about, what other information would be beneficial for the board at its next meeting to talk about this strategy. Are there areas that you really would want the policy for focus on, and are there aspects of what we just talked about that you might want to be eliminated and just focus on a portion of? And what would you ask of your committees, be it the Stakeholder Advisory Committee or the Data Advisory Committee, to examine for this strategy? And And then how would you rank this one as in terms of your priority?
Thank you, Janine. Really comprehensive, full presentation. I'm curious if any board members have some initial thoughts or responses, comments. Jane.
Okay, thanks, Shane. That was great. So a couple of things. First, it seems to me that starting with the database like Massachusetts has of ownership is rather than an after fact, it's a before the fact. Especially, Janine, like you were saying, you want to have that so that if there is M&A review, whoever's doing the M&A review understands who owns what, how consolidated is the market, what services are at risk or not. The other thing I want to note is along the lines of reporting and ownership, currently health insurers, domestic health insurers like Primera and Regents and Kaiser Permanente submit annual financial statements to the Office of the Insurance Commissioner, which already have extensive reporting about ownership and affiliations. Like I literally am thinking about Schedule Y, which is an org chart, which gets specifically at vertical integration. So I think it would be really helpful maybe to have the data advisory committee looking at what data is already reported, how complete is that data, and is it how can it be used, or should that reporting not happen, but instead this kind of reporting happen? I think that would be helpful information. And then also to have them take a really, really close look at Massachusetts reporting system and what their experience has been. And then the only other thing that I would note is on slide, I don't think there are numbers, but I think it's on slide 65 on the enhancing business oversight. One bullet that I would suggest adding is what types of conditions could be imposed on a merger or an acquisition. So maybe getting some examples from colleagues in Oregon about the kinds of conditions, or New York on their C of N, and then really getting a sense of how those conditions can be designed to get at the risks that we would be trying to avoid. So just some thoughts.
Thank you for that, Jane. Others?
See, Greg Marchand has his hand raised.
Oh, great. Go ahead.
I had a couple questions. First, based on what you reviewed, which states have the most controls or ability to control some of these issues?
Well, there's I'd say the ones that have actual approval authority beyond taking them to court are probably the ones that have the most authority. Again, a lot of these are but Massachusetts has been at the collecting of data for a while, since 2012. But I'd say that, Oregon, Massachusetts, and California are probably out in front. Yeah, for doing the most at this point. New York, catching up.
Thank you. And then if don't mind another question, and maybe this is a Jane question, but so do all health plans then have to report in Washington if they're acquiring provider entities?
So
or
Greg,
if they have required?
They have to report owned or affiliated provider entities. It's not, the reporting isn't like triggered when the acquisition happens. The reporting would be reflected in the next annual report that's filed with us.
Yeah.
I would also note that our law relates to domestics. So Aetna, Cigna, United Healthcare are not required to submit those annual reports.
Jane, for clarification.
No.
Domestic, by
Domestic insurers, sorry.
You mean companies that are in the South
That are,
state.
right, that are
In
born and bred in Washington.
Yeah, and one thing about Massachusetts is that they have an annual reporting cycle for that database, but they also have some legislation or statute that requires notice of a impending merger and acquisition as well. So it's complementary. Otherwise, you would just get it like Jane's getting it on after the fact.
Ingrid had a question.
Janine, thank you. This was so helpful, especially just hearing about how different states are approaching this. Jane, I just want to agree with your suggestion is that it seems like a natural step one is we have to see the picture of what's going on. I know that's been so difficult. That seems like a no-brainer. I know when we did the sticky exercise, we were thinking about levers, and one of our criteria was, well, what's the value add of this board, this issue? And on this one, I'm thinking about the AG's office and increasing AG oversight, like you've described is happening in other states, is top of mind, but also intriguing the idea of a health entity complementing the largest merger oversight that the AG does. So that's an interesting thing to think about for Washington State. And then thinking about if AG is, what kind of support could this group provide to AG's office and their work? So the cost price data that we just reviewed with John and Tom, could we be looking at how price and cost changes pre and post merger through that data set? So just some thoughts. Thank you.
Others?
Janine,
go ahead, Kim.
I just had a thought that I know that we started this whole piece about mergers and acquisitions and private equity with some very brief comments about the effects of consolidation. You know, what appears to be, what can occur, what may occur, things like that. So some language like that. And so what that has led me to wonder is what data, studies, research, etc. Exist that actually show, demonstrate, articulate the impacts and the connections. Because I think that could be, of course, compelling. Many people who are close to, who are in policy circles, you know, are, I think, aware and could talk sort of qualitatively, you know, about the connections and relationships and impacts and effects and consequences and all that. But is there actual, who has studied or reviewed and can present essentially compelling case, you know, or scenarios?
Yeah, there's a big body of work on the consolidation work and out of the FTC. My question, building on your question, is, Janine, what are we learning about the cross-sector state arrangements? Because we are increasingly getting hit with kind of East Coast impacts and or the consolidation at a more macro level nationally. And then when you look at the different market segmentation and how some of that is being jockeyed and manipulated and maneuvered. I worry that maneuvered, no Freudian slip there, but I'm just wondering if Massachusetts or others are beginning to look at that. So for example, you know, national MCOs versus local, or national, your point, domestics versus, so I just would ask, when we come back to this, to have further discussion that we consider that, because we are dealing with health systems plans and everything that is shifting into a much more consolidated, tricky situation. Even leadership coming in on, I mean, you know, when you think about kind of hybrid work environments and now more cost allocation, and I just get increasingly concerned about the accountability for some of this mega consolidation and cross-sector work. So lots.
Yeah, I think there's some studies starting to come out on that, but I didn't see in the latest reports on the Massachusetts that they had started to look at that specifically.
Yeah, I know there's a lot more talk about it, especially with Medicare Advantage and just, again, more and more of the consolidation. So I know we are really over time. I think we need to stand and take a stretch break. This topic will be coming back to us. So Janine,
There's two hands, sorry.
Oh,
two
I'm
hands that
sorry.
went up, sorry, so, Jody Joyce and Greg Marchand for the.
Great. Then after that, we're gonna do a quick break and then we're gonna come back and we're gonna adjust the agenda a little bit.
Great, thanks. This is Jody. Just real quickly. I think that we have to think about, you were mentioning MCOs, but when you think of delivery systems, most of them are multi-state now. So what does it mean for the state of Washington when you've got a Prov and a Peace Health and a Kaiser and a United/Optum who are in multiple states or everywhere? And so I don't know the answer to that, but I think we have to be very clear-eyed about a state-specific strategy will fail because the entities we're talking about are already way beyond state borders.
Thank you for that, Jody. My point exactly. You said much better. Greg, go ahead.
Maybe a topic for next time, but has there been an in-depth look at on the regulatory situation in Washington and what things might be that we should do to help competition? So I guess it's kind of a little bit of the opposite side of, are there things in our state that make it harder for new folks to come in? I don't know how we would do this, but I just think it was brought up on one of the slides, but I don't know, has this really been looked at?
Really great point, Greg. I think there's a lot of components in this assessment of exactly where things are at that we can go a little deeper. So, all right, again, thank you, Janine. And we're going to take a quick, let's see, what time is it? 2:55. How about we try to convene back at 3:05? Okay. So let's do a quick 10 minutes back at break. Hey, we'll do. I'll give myself a little. Oh, yes,
We had to go upstairs because she didn't.
Thank you.
So she.
All right, are we unmuted?
Are unmuted and our camera is going.
Okay, so if you are listening in, we are resuming and welcome back to all of you. We have people coming up to the table. I want to just suggest that we continue to forge on with the agenda that's been proposed and not cut anything, but we do run the risk of, if we cannot kind of shorten things or we go too long, that we will have to go over a few minutes. But I would ask people to be okay with that. And if you have to leave, we understand. So let's go ahead and begin our next topic. Zach from HMA is going to present and lead the discussion on our second strategic lever, facility fees, and this is under tab 6. So take it away, Zach.
Good afternoon, everyone. Can you hear me okay?
Sure can.
Great. My name is Zach Sherman. I'm a managing director with HMA, and I'm out of the Boston office. I am pinch hitting a little bit today for Gary Cohen, who is not able to be here today. Really appreciate the opportunity to talk to you. And as the director mentioned, I'm gonna talk a little bit about the policy lever that is around examining facility fees. And I can be quick and move through my slides in the interest of time. So just in the first slide, why is this important? Facility fees are fees charged in addition to the services that consumers and patients get that are not always directly related to the service that is provided. Traditionally, the costs are associated with administrative and overhead costs associated with the hospital or the healthcare system. And there's been a growing prevalence of its use over the years. Washington State does have a public disclosure requirement that is specific to hospital systems and hospitals and health systems, but it's not universal. And importantly, it does not touch providers that charge facility fees that are not associated with the health system or hospital. So there is a public disclosure and transparency law, but it is not as broad as it could be. The policy itself, the facility fees are important because they add costs. They add costs to both patients and purchasers of healthcare, and they show up as oftentimes as a second bill that can result in additional cost sharing, additional out-of-pocket expenses for consumers. Next slide, please. So there, as I mentioned, there's a public disclosure law, and there are some cost data associated with that. In 2022, hospitals in Washington collected more than $125 million in revenue associated with facility fees. Because there's no required reporting of facility fees charged for providers that have them that are not affiliated with a hospital or health system, this $125 million number is likely understated. And there are likely to be other, additional costs in the system associated with facility fees. Generally, hospitals have stated that facility fees make it so they can be operational, so they can pay their bills, so they can provide services to the community, and that they are not paid adequately for professional services and emergency services that they provide on a 24/7 basis. Next slide. What have other states done? Similar to the state of Washington, several states do require public reporting of facility states. Other states go further. A few states have prohibited facility fees entirely or in part. Those fees, those prohibitions range from largely not being allowed to only being allowed for on-campus or hospital, outpatient facilities that are within a certain proximity of the hospital itself. But that is not the case in the state of Washington, and affiliated system can be any amount of distance away from its hospital that is charging the facility for which the facility fee is associated. And, as I mentioned, some states have prohibited fees charged by hospitals that are for services that are provided off campus, not on the campus where the hospital is. What else is out there? Congress has kicked around, just going back to the previous slide real quickly, Congress has kicked around as it relates to the Medicare program requiring, a way of getting at this issue is by having site neutral payments where outpatient and professional services are the same regardless of where they're being performed. And that is one way in which you could get at addressing these issues at the federal level. That legislation has been kicked around quite a bit and is still, is being deliberated on, but is not, it's not clear if it's going to move forward. Next slide. This slide has Washington specific data on both patient activity as well as revenue. Total reported revenue from 2017 to 2022 has ranged, has stayed fairly flat, but is well above $100 million each year. And the number of patients that have had claims or encounters associated with facility fees has risen quite a bit from 1.1 in 2017 up to 1.31 million in 2022. And the average facility fee assessed was $100 per patient encounter. Next slide. As I mentioned, there are some limitations in the public disclosure law. One of them is that each facility has to report on where the facility fees are charged, how much in revenue is collected related to facility fees, and what the minimum and maximum facility fees charged were. They are not required to disclose how many were charged at the maximum, and other data that would be helpful in trying to assess exactly how prevalent by system this issue is, and what these fee range charts show is that there's a lot of variability.
Let me turn on the screen.
Whatever that is.
Someone very excited about facility fees.
We thought it was your dog, Zach.
So, the reported data lacks transparency in terms of how many times in particular high facility fees are being charged to consumers. Next slide, please. So what's the upshot? How does this impact Washingtonians? It's significant. Research shows and indicates that facility fees become more prevalent as a result of consolidations, and that it results in rising costs. Physician practices, independent providers that are bought or acquired all of a sudden have facility fees associated with services that are added to the bills for consumers, just as the implication of being now affiliated with the system that bought them. For consumers, fees vary by system and provider and can add up quickly and are not always something that consumers can be aware of before going in for whatever service that they're accessing, and sometimes they're only realizing the cost of it and the associated cost sharing affiliated with it when they get their bill. Data from Massachusetts shows that services such as struggling with that word, but the services on the screen can be over $1,000, which is double the price of paying for those services. For purchases, these costs can add up quickly. One state employee health plan stated that facility fees charged for COVID testing conducted in outpatient hospital settings range from $53 to $100 per test, resulting in $350,000 in additional costs over just a few months. So going to the next slide, what could be done about this? What are the policy options? What are the levers? More could be done around transparency. Washington already requires notice before a hospital charges a facility fee and requires reporting on some of these fees to the Department of Health. However, fees charged by other providers are not subject to these requirements. And advance notice requirements could be modified to require consumer disclosure before the fee is charged. And reporting requirements could be more expansive. They could be expanded to the providers and facilities that are not subject to the public disclosure requirements, and those include provider offices, labs, x-rays, therapies, which could improve overall reporting and give you a better sense as policymakers of the magnitude of this issue and how much of an impact it has on healthcare costs. The other policy lever is limiting the prevalence of facility fees by either outlawing them completely or prohibiting them or limiting them in some way to select services provided on a campus or specific to a type of provider type. So we have a little bit more about each option. So around increasing transparency, advance notice of the fee allows patients to know the cost of obtaining the service and have clarity on the amount that they'll be charged before they go in and access the service, potentially giving them the opportunity to shop for comparable services that don't have a facility fee. Reporting of all facility fees charged would, as I said, increase transparency and accountability and give you a full sense of the magnitude, who's charging, what those total costs are. Would this be an effective lever? Full reporting will increase transparency on the scope of the issue. It won't necessarily, other than, the bully pulpit that comes with full transparency, it won't have a regulatory or limiting effect on the ability to charge those fees. And then around advance notice requirements, consumers don't always, patients don't always have the ability to shop for services for a number of reasons. So public disclosure, advance notice is nice, but it may not change their utilization behavior where they access those services because they don't have a choice or they don't really, or they don't have a choice for whatever reason, access to providers, transportation, or they don't know how to go elsewhere. So what other states have these policies? Colorado, Florida, Indiana, Maine, Massachusetts, Minnesota, New York, Texas, in addition to Washington. And then the other lever, a little more detail around limiting or prohibiting facility fees. What difference does this make? It could have some effect, but it may not be a silver bullet or address the issue entirely. It certainly could limit the impact of facility fees, and it could resolve some of the impacts around cost sharing, increased cost sharing for patients. But it is possible that systems, hospitals, and other providers no longer able to charge a facility fee could account for that through some other increased costs elsewhere to make up for lost revenue. So listed on the slide is the states where there are limitations, and then the few states, Connecticut, Indiana, and Maine, where there are some more comprehensive prohibitions of facility fees.
Great, thank you, Zach. So I think the actions are similar to the format we've seen before, and I'm just going to open it up to conversation or questions or thoughts so far so we can give staff feedback on more direction to come back to us with. What are people's thoughts about this? And Bianca has her hand up.
Yes, thank you. Really interesting presentation on facility fees. I'm curious with this option of potentially providing more consumer transparency how is insurance playing a role in the coverage of facility fees? I didn't quite catch. So if you're privately insured, how is health insurance covering it, I guess?
It's my understanding, and Zach can help round this out, Jane too, but that it really varies. We don't have, I think, a real clear enforcement mechanism or monitoring.
Right, I mean, so Medicare and Medicaid, there are two claims filed, right? In a transaction, a professional claim and a facility claim. And a facility fee would show up in the facility claim. In commercial health insurance, at least according to the folks at On Point, it tends to be a single fee that's paid to the hospital outpatient department that doesn't clearly distinguish facility fees.
So if I can
challenge there.
Yeah, so if I can follow up, how would consumer transparency of facility fees before they get a service so they can shop ahead of a service, how does that work? Or how is that envisioned to work? I don't, like, most of the time we don't even know the cost of our provider services until after it's done. So I'm just having a hard time really understanding that as an option. Thanks.
Yeah, it's a good question, Bianca. I don't know that level of specificity is, right now, a hospital would know how to answer that question.
Right.
It's likely that they wouldn't be able to give you that breakout, but we can ask staff to look into that. I personally am curious about Indiana and how they moved towards kind of the size and then what they did to incent kind of keeping things clustered. Because I am very worried about what we just heard about inefficiencies with our hospitals and how all the development and the sprawling campuses, the detachment and all of the systems charge and how that varies. So I'm wondering if we could get a little deeper dive into what Indiana's thinking. And of course, we want to hear what Massachusetts is thinking as well.
It would also be really helpful. Connecticut actually just passed a bill, I think in 23, that has really, Bianca, really significant notice requirements. So just to get a sense of how they're implementing, I mean, one thing to think about is the Center on Health Insurance Reform has been doing a lot of work on state facility fees. And so it might be worth seeing if Christine Bonahan from the center would be willing to do a presentation to the board. And then, I mean, you know, do we want to hear from hospitals and the center to be able to have all sides be presented, and maybe some ambulatory surgical facilities, which are frequently owned by physicians, to get perspectives. But I think the Center on Health Insurance Reform probably has a fairly good sense of what the states are doing and lessons learned.
Great suggestions.
This is Jody. Can I just make a comment?
Yeah.
I think geography plays a role here. These states, other than Maine, these states are small, populated, with lots of alternatives. And when you think about what Washington State looks like, there are just different dynamics that could come into play about, especially if you're asking for patients to participate in any way of having more transparency around what this looks like. I just think that how we're configured as a state and how much geography we cover, and how much choice there is, it needs to be considered, because some of these, I think just competition and alternatives might be playing a role in how they're able to apply some leverage that might be more difficult when you think about what the geography of our state looks like.
Great point. Greg, go ahead.
Well, I want to acknowledge that transparency and things like that are tools. I'm really hesitant to push more onto a patient to try to figure out. And I don't believe in a lot of situations where facility fees are charged, people feel like they have the ability to shop. I also just would comment that I think facility fees are an egregious revenue grab that I know, you know, there's various tactics that can be applied, but why does Children's Hospital in Seattle charge facility fees for, you know, behavioral health counseling? I just think it's appalling. So I think there's lots that could be looked into this further. I just think it's one more kind of egg in the face of many hospital systems and the data we're seeing related to their behavior.
Thank you for that comment, Greg. Don't push more onto the patients, and yeah, just really, I worry about how the transparency thing, what will, so we push one thing down, how will it pop up somewhere else, and how will we monitor, and how will we enforce? Go ahead, Eileen.
Yeah, I mean, it's just an unfair thing that folks, you know, somehow justify because it just generates more revenue.
Yep, great.
I just have to throw in that when we passed the original bill about the transparency for Washington State, that it came about because in Yakima, and I don't remember which hospital it was, but one of at that time they had two. One of the hospitals bought a physician practice in orthopedics, I believe, and made an extra $1 million out of it in 1 year. And the people in Yakima bitched to their legislator about the increase in costs. So that was how the original, at least this is what we were able to pass at that point, was some transparency. So it's not necessarily that it gets pushed onto the patients, that patients wanted to know like what the heck was going on. So.
Ingrid, you get the final comment, and then I think we'll move to our next topic.
Okay, I'll be brief. Share everyone's skepticism about the value of transparency in this one, because especially when it's a lot of sometimes it's a very large fee, but sometimes when it's just another $100, I mean, people just don't have bandwidth to pay attention that that's coming, or when it has hit them, what it is. So Zach, my question to you just for follow-up is if we could have more identification of the sources of data in your deck, and just thinking about our data advisory committee's capacity and ability to drive down harder on this cost, because do use our cost driver analysis. It feels like we have more to add here on the data, and want to compare with what your data sources currently are in that deck. Thank you.
And Sue, just super quick, we had done, OIC had done, our data analyst had done some looking at DOH facility fee data and identified situations where like a hospital reported 1 year, didn't report the next, then reported the next year. So maybe to ask the data advisory committee to look at the completeness of that data and what recommendations that they would have to make it more complete, including giving the Department of Health Enforcement Authority related to the reporting that goes to DOH.
Great, thank you for all those robust comments. It's clear that the board wants to come back and dig deeper. One more question, you said?
No, could I just follow up? And is there any questions that you have for the other advisory committee, for the stakeholder advisory committee? I just want to check in. I know that's a question on the slide.
Yeah, well,
a lot of assignments for the data committee, so I just want to check.
Yeah,
That's okay.
I certainly I hear the comments about we don't want to push more cost to consumers, and it'd be great to get their perspective or about no facility fee or the size. I do think Jody's point though about kind of the large geography and what do we do with our smaller ones, kind of like with what looks like Indiana moved towards. So yeah, I think the stakeholder advisory group should definitely think about this strategy, make some recommendations to us. Okay, Zach. Yeah, about the size of the state.
No, there was another one. Did it come in the chat?
Yeah.
I saw it pop up.
Jody, it might be easier for you just to weigh in. I think you put something in the chat.
Transparency.
Yeah. It was just the point again that if you're transparent about facility fees, but if it's the only facility you can choose, then our residents are not going to be very happy about that. So,
Okay. All right. Let's continue on this theme about consumer medical debt. This is kind of a carryover issue from our No Levy presentation, which I know many of you have contacted me about. I'm really grateful for the AFF giving us that information. Liz, I think you're going to facilitate further conversation and discussion on this.
Yeah, and we're gonna be pretty quick, but just to sort of recap, level set from the conversation last time about what the kind of rules of the road are currently in Washington, and for this board to think about, is there something else that we want to do to address medical debt? There are 6 states that require hospitals to provide a minimum amount of charity care. Washington does not, compared with our neighbor Oregon, which uses a formula considering revenue and operating margin. Washington requires a waiting period before medical debt can be sent to a credit reporting agency, but doesn't prohibit it, which some states do. And finally, a few states require hospitals to offer payment plans to low-income and uninsured patients, and Washington does not. So those were 3 of the big things that were talked about or mentioned at the last board meeting. And just wanted to circle back. Are there additional questions or information you'd like to know about any of these options or any other policies that came to mind after digesting the presentation last time? I just want to make sure we talk about it.
Well, I just have a question on the first one, because we do have a law about charity care that we expanded just a couple of years ago. So.
It requires that it be offered. I don't know that there's a minimum expenditure.
Oh, expenditure,
So
okay,
maybe looking deeper at that.
yeah, yeah,
And
okay.
as we know, we don't necessarily have compliance with charity care policies. We
Well-
don't have the commensurate enforcement abilities unless something really egregious crops
Right,
up.
yeah.
So I would say from a state agency perspective too, the operating concerns around enforcement and monitoring really important.
And then there was legislation this past session that was introduced around medical debt. In terms of, right, showing up in credit, and federal law says medical debt over $500 cannot be shown on a credit report, but it doesn't protect medical debt below $500. So there are, I think, a number of policy options there.
Liz, the other thing I would like to get a little bit more of a refresh on, there was a big NPR article recently about hospitals, I believe out of it's either Utah or Colorado, that are hiring intermediaries and confusing people even more with the recovery payments and kind of disguising their medical debt collections. And so I think we need to go defensively upstream to say, because it's becoming more of an employer-sponsored issue, I believe we have to get much more aggressive about saying no right from the get-go, or some of that kind of false entrapment into debt recovery. So I'd like to have more information on that. Are there any hands up for? I saw Greg's hand. Greg, go ahead.
Does anybody know, is there any correlation between the states that require a minimum amount of charity care and then the overall hospital efficiency or other measure that we've looked at? Like, does it help?
Good question. That's a really good question. We'll get our team on it and we'll get more information to see what we can find out, Greg. And I think Margaret, your hand is up. Go ahead. Margaret, if you're talking, you're muted.
Thank you. I'm wondering how much of this medical debt is due to patients going to non-preferred hospitals and doctors. And some of that has to do with how complicated our benefit designs are and how difficult it is for people, particularly when they're in an urgent situation, to figure all this out. But one of the things we could look at is whether there should be some limit on non-preferred provider charges.
Thank you, Margaret. That's really helpful. And I see Liz taking note. Going to get back to us with some ideas about that as well. All right, that was what I was. Yeah, that's what I was hoping for. The other thing that just was shocking to me when no one presented was just how much more of an employer-sponsored insurance issue this is. And so I'm just wondering about anything we could do with Department of Labor and the ERISA, kind of just what are they doing around? I've heard there's more activity at DOL, but I'm just wondering if we need to look into that alignment a little bit more. Okay. Liz, you got a lot there to go with. I'm going to keep moving us along.
I just want to say, so I like that comment that because of so many more people now have high deductible plans. And so, it just seems like medical debt, one way of thinking about it, which is pretty outdated, I think, is that, oh gosh, people with very low incomes, people with no healthcare coverage, et cetera, when we learned, oh dear, that's not by any stretch the full story now. And so you have people that are covered and that have an employer-sponsored plan, and they think that they have health insurance.
Everything's fine,
right?
yeah.
Oh, we can also send the message to the exchange board too about let's get to all standard plans for our state and more of this benefit alignment. So I know it's thank you.
Also, as a potential resource, we have a report due to the legislature actually on July 1, I think. Yeah, July 1. Looking at options to reduce or eliminate cost sharing for maternity care services. So Milliman's doing an analysis of like 4 or 5 different options. And we're happy to share that as soon as it's released to get a sense of what does it mean in terms of PMPM impact if you eliminate cost sharing or reduce it.
And Shane, I'm so proud that you're saying that. And of course that goes with Mandy's earlier comment. Let's see what our advisory group has to say too, to augment more of this discussion. See what other brilliant ideas they have. Because really it is such a consumer protection issue, especially as benefit design and things have gotten trickier to portray with all the choices of plan selection and whatnot. Okay, Liz, you asked, we answered. All right, we are going to move on. This is our next topic is from Joe Dielman from IHME. He's going to present and lead the discussion on the draft of the DEX report for the feedback from the board. This is going to be really fascinating. And your DEX report is under tab 8. And Joe, I'm going to turn it over to you. I know you've been all over the country in the last 24 hours because we've talked. I'm hoping you're on our time zone again.
Yep, I am. Thanks, thanks everyone. Thanks. It's nice to be able to present today on behalf of the Analytics Board Initiative. This is our kind of preliminary disease expenditure report, and I'll explain what that is in a moment and then kind of walk through it. Next slide. So this is just a refresher on the last few months since I presented last to the board. So the last presentation was in December, where the cost board endorsed the ASI, the Analytics Strategy Initiative's analytic strategy. And so we kind of identified and the group voted or endorsed 3 primary strategies. And I wanted to remind you of what those 3 were. The first is to complete a project that estimates spending and utilization per capita and per prevalent case at a relatively granular level for the state of Washington. The second part, B, was to do direct age standardization and indirect risk adjustment to look at trends over time and comparisons with across the counties, but also with other states and across time. And then finally, the last part is to look at those changes and those differences and decompose or break them apart into known drivers. So that's kind of what we were charged to do. The next slide. And then came February, and I'm kind of highlighting the sequencing here, is that our three kind of mandates for the analytic strategy initiative came before the board met in the retreat and kind of came up with the kind of 4 strategic objectives of the board. Next slide. And then the third thing that's happened is the team that I lead here at IHME has completed a major project that we've been working on really for the last 3.5 years that looks at estimating spending by county, by age, by sex, by type of care, by payer, and goes through 2019. This is a project that obviously came way before the Analytic Strategy Initiative, the Analytical Strategy Initiative, and predates it by a long shot. But point 4, thank you, is that we wanted to use that previous research that was funded elsewhere and done separately to ask if there's anything we can learn about Washington State. And so that's where this preliminary disease expenditure report comes from. We want to be really clear and candid that this is not, a response to the kind of direction of the board necessarily as far as the retreat and the 4 objectives. And it is coming from data that was produced elsewhere. That's why it only goes through 2019. And it is, part of maybe the nicest thing is it can be an example of some of the things that we can do moving forward. So as we progress, presenting similar sorts of estimates and analyses at a later date, with Washington-specific data as the input through 2022 is a distinct possibility. So this is a great opportunity to get feedback on what may or may not be useful and how to tailor the results for the cost board. So, next slide. So the 2 main questions are, number 1, we have this very preliminary report. Are there changes or tweaks that you want to see to it before we consider it done and finalized? And then 2, if we use this preliminary report as a reflection of what we could do in the future, are there bigger changes? Are there more meaningful changes that we can't do in the next few weeks to the preliminary report, but with more time and consideration, we could do substantially different for what we are reporting, at the end of 2024 to the cost board. So those are the 2 main questions. Are there little tweaks and are there big changes that we could consider to make this more useful to you, the cost board? Next slide. So it's really important to acknowledge that the data that's feeding into this report right now isn't the Washington APCD. It does include a lot of Washington-specific data. So we have 550 million insurance claims and 30 million administrative records from hospitals. So there is, it's a very strong foundation of data, but it is not specifically the APCD. It's also important to recognize that when we talk about spending by disease, we're looking really about where the disease that the spending is attributable to. And so it gets a little technical, a little wonky, and I probably won't go into all the details. But the idea is that if you went to the doctor for diabetes, but you have heart disease as well, and the heart disease drives up the cost of the visit, then that extra spending would be attributable to heart disease. And so we adjust for comorbidities in that manner. And then pharmaceuticals here, just to be super clear, are pharmaceuticals that are bought at a pharmacy. They're not pharmaceuticals that are administered inpatient or at a clinic. And that's a limitation. We include that spending on those drugs, but it just falls into the inpatient category or the ambulatory category. So next slide. So a couple results. So just start with a simple comparison of where Washington State is at. This is spending per capita in the dark blue and age standardized spending per capita in the lighter blue. And Washington pops out in the red. You can see that Washington in per capita terms is the 16th lowest cost as far as spending per capita, with some notable outliers like DC and Utah that are really driven by their specific populations. Otherwise, we sit, somewhat in the middle of the pack, a little bit lower than the mean or median. Next slide. As far as where the money's coming from and where the money is going, remember, this is kind of a 40,000-foot perspective, but in Washington State, we spend more money on 65-year-olds to 69-year-old than any other population. That is not because that's the most expensive group, but because of demographics. So that's where we have a lot of people, and you combine that with the figure on the right, which is really the spending per capita. And so I think most people in this group know that, as you get older, the cost of healthcare goes up on average. That's true at a population level, and in case for most people, for individual level as well. And when we combine that with the demographics of the state, we get that figure on the left, that there's a lot of spending at the population that's really just entering the Medicare kind of stage. As far as types of care, there's a lot of spending on ambulatory care. In our world, that's a really big bucket that includes ambulatory surgical centers, primary care, urgent care centers, outpatient that's in a hospital versus a clinic. All of that kind of falls into that green bucket on the right as far as ambulatory care is concerned. The next biggest is inpatient care, and that's that kind of dark purple color on the right as well. Next slide. So again, the goal is to just use these numbers we already have and try to explain what we know about healthcare spending in the state. This looks at those 7 types of care that we were just talking about and makes them columns of this table. And the 4 payers that we look at are Medicare, Medicaid, private insurance, and out-of-pocket. So again, this is a 40,000-foot perspective to just kind of understand in absolute terms where the resources are going and where they're coming from. And so in our state, private insurance is by far the largest, with $24 billion of the $51 billion that we're able to capture, so just a little bit less than 50% of the spending. And over 50% of that spending from private insurance is on ambulatory care, so a lot of outpatient care from private insurance. Medicare is the next largest with 14 billion, and Medicaid at about 8 billion. Next slide.
Wait 1 second.
Oh yeah, go ahead.
He wants to ask you a question.
So Joe, after I looked at this, the question I had is on nursing facilities. What are you defining as nursing facility? Because Medicaid pays for 75% of the nursing home beds. So yeah, this must just be skilled. That's what I was getting at.
So this is inclusive, this is SNFs, this is short-term and long-term. It is, the Medicare is going to be captured. So the key part is that it's capturing short-term and long-term. And so the Medicare is a lot of short-term as well as those first 90 days of a long-term stay.
No, it was the Medicaid, not Medicare. Medicare doesn't pay for very much.
Well, no, that's what I'm saying is Medicare is the biggest here at 0.8. And what they're covering is more the short-term case here.
Right.
Exactly the point you just made. They don't cover after those first 90 days the long-term stays. Medicaid is capturing it, but a lot of the spending is coming out of pocket, and that's really what what the slide is meant to show, is that of the 3.2 billion on nursing facility, 1 of the billion is out of pocket, and then Medicaid a large piece too.
Joe, we can come back to this later, but that one looked off to me too, Eileen, to your point with Medicaid, the Department of Social and Health Services, non-post-acute. Post-acute is captured over here at Healthcare Authority, but the post-acute is partly covered under Medicare, largely covered under Medicaid. So we're just all 3 aging experts are kind of going, that doesn't look right.
Aging for a lot of reasons.
Aging. So this is data straight from the state health expenditure account. So it's easy to reference, but we can dig into it a little bit more too to try to understand what's going on and why it doesn't line up with your expectations. Yeah. Next slide. Wait, maybe Sue, just the 3 ones that you were concerned about was nursing facility. Could you go back 1 slide? I just want to make sure for my own notes where the concern lies. Nursing facility, I understand. Was there another spot?
No, that's
No, it's just that there are post-acute costs that show up in inpatient, and then there are costs where I think you're bucketing the nursing, the aging kind of expenses in that through to 3.2 billion. It just looks off.
Okay. Okay, great. Thank you for that feedback. Again, the definitions are those that are used by the state health expenditure account, which are sometimes a little counterintuitive. And so we can flesh those out more if that's useful. So, next slide. So, the last slide was just looking at the total dollars and where it's going. But that's much easier to look in terms of, per beneficiary. And so this slide is, highlighting that, well, more spending is from private insurance than any other major payer. In per beneficiary terms, Medicare, the older population, is much higher. That doesn't surprise any of us. In our state, just a little bit over $10,000 per beneficiary. Medicaid and private insurance are about half that, and then out of pocket less than that as well. Next slide. So this is the growth that we see from 2010 to 2019. This is not inflation adjusted, not age, sex adjusted. It's raw numbers going from, over the course of the time period of our study. You can see growth in all of the categories, but in particular, in this time period, you can see Medicaid growing in our state, as well as ambulatory care being one of the categories on the right that grows the most. Next slide. So continuing to kind of focus on growth, one of the kind of interesting things, this is per capita growth, so it looks different than the numbers that we've been looking at today. In per capita terms, because our state has grown a lot over the course of 2010 to 2019, we see that the growth rate again is again not adjusted for inflation, but has been adjusted for population size, is 2.9%. If we adjust for age, of course, it's lower than that. That's the way it is for all of the states. And ultimately, we can see that from 2010 to 2019, we're the 8th lowest growing state. Again, lower than the mean or median, certainly not as low as some of the other states, such as Rhode Island or Wisconsin, that we would like to compare ourselves against. Next slide. So this slide is starting to kind of decompose or break apart the increase in spending that we saw from 2010 to 2019 and asking which categories grew the most. And so the dot here lines up with the x-axis, which is the change in total spending, annual spending, from 2010 to 2019. Ambulatory care increased the most. And you can see by the colors on the bars that the big increase in ambulatory care spending was really about the price and intensity of care. So the fact that that is a green bar is really highlighting price and intensity. If anything, utilization went down. It's a very small piece and went to the left. So the story here in ambulatory care increases is one of price and intensity. We see that population size and age went up as well, but the really big bar is green. That's true for inpatient care as well. The hospital inpatient care went up the second largest amount. Here you see a nice substitution that utilization did go down, which I think is something that, there's been a push for a while to limit bed days. And to increase, to increase discharges or to speed up discharges. But what we've seen is that price and intensity per day has gone up at a rate that's faster than utilization has gone down. And so that, we see that with the fact that the green bar is bigger than the orange bar is negative. So you still have this major increase of resources spent on inpatient. The other categories, yeah, go ahead.
I want you to restate that again. I heard you just say price and intensity are a leading state-ish.
Exactly. So, this is our data set, but again, coming from a different place, but highlights some of the same themes that we've seen before, that in the case of inpatient care, it's not so much utilization. It's not people going to the hospital more. If anything, people are going less and staying less. But it's per day that's spent there, the price and intensity of care has gone up dramatically. And so that's really leading to the increase in spending.
Thank you.
Yeah. Other places of growth is dental care, and we'll come back to that in a moment. But we've seen that prices haven't changed much in dental care, but utilization has gone up a little, and that leads to this bar to the right, or the dot to the right as far as dental care. Next slide. So this allows us to look at that same figure now, but disaggregated by payer. And I think it's useful, to really think about Medicare, Medicaid, and private insurance as quite distinct, and highlighting that they actually have different factors that are leading to increases. So in all of them, ambulatory care is the largest increaser in spending from 2010 to 2019. For private insurance, it's all about price and intensity, where for Medicare and Medicaid, it's much less about price and intensity. And then if we look at inpatient care, that's the next line down, we see green bars again as really being the dominant part of the increase. So again, we see that substitution utilization is going down, but for inpatient care, but price and intensity is more than offsetting any reductions in spending that would come because of reductions in utilization. So that's true again for all of the payers. It's true for Medicare, it's true for Medicaid, and to a slightly lesser degree true for private spending. Next slide. So a little harder to think about how this is immediately policy relevant, but I think it's really useful to be aware of, is we can break the spending down by disease, and ask where is the spending growing the most, and where do we spend the most on and what diseases. And so this is our most granular categories, and I think I put it in the most granular because I think it surprises people that there's so much spent on dental care. And so the number one health condition, again, these are, if you were to bucket these different ways, you would, a different thing would be on top, but oral disorders, that includes orthodontia, it includes cavities, any sort of oral surgery, all comes into that bucket that has $3 billion. Also at pretty close to $3 billion is joint pain. So that's essentially hips and knees. Followed by diabetes, and then more musculoskeletal disorders, and it's low back and neck pain at about $1.5 billion. As far as the spots where you see growth, the things that really jump out, I think, are heart failure and anxiety disorders, which have some of the highest growth rates. And then we also see breast cancer spending growing a lot during this time period, as well as joint pain. Next slide.
This is pre-pandemic, right? Yeah, 2010, yeah.
We're
It is,
coming it would look a lot different for probably depression and anxiety post-COVID or during COVID.
Yeah, I guess I would speculate it would be bigger, if anything, not only the spending but the increases over time. Next slide. Yeah, so these are the health conditions that had the most growth in absolute terms between 2010 and 2019. Again, there's the age effect is pretty minimal here, but the story really is that these are health conditions where we see a lot of new resources going in the state, and I think they're places to focus some of our attention. Next slide. So just like we did before, we can take some of these diseases that had the largest increase in spending and pose the question of why was there such a large increase in spending? And I think it's valuable because you see really different stories. For joint pain and anxiety disorders, it really is all about ambulatory care. We spend more on ambulatory care for both of those diseases, but it's really, very different kind of underlying factors. So for joint pain, it really is price and intensity has gone up dramatically for ambulatory care. So it's not seeing the doctor more or less, but it is just that when you go to the physician for joint pain, the cost is substantially higher. And then on anxiety disorders, the biggest bar is orange. And that's actually more utilization. That's people seeing psychiatrists, seeing counselors, higher frequency, especially for anxiety disorders than before. And then in diabetes, it's really, this kind of story of a number of things really all simultaneously increasing. Ambulatory care went up, but so did pharmaceutical spending. And again, the green bar being price and intensity is really steals the show as the biggest bars that are pushing us to the right. So I see people are dropping off, and I understand that it's 4. I'll go real quickly through the last few slides. Next slide. So one of the advantages to the report is that we can break things out by county. And so here, red is the areas that have the most spending per capita in the state. We know that those are some of the more rural areas and some of the places that have lower health outcomes. And so we see that the spending is the highest in those areas. Next slide. The other thing we can do is look at county-specific spending over time. And so this is a little bit wonky, but on the x-axis is just the total amount of spending in age-standardized per capita dollars. So the more to the right, the more spending. That's really what we saw in the last figure. But on the y-axis, going up and down, is the growth rate of spending in those states, and in those counties. So you can start to ask, where are more resources going than before, and what counties are we seeing less growth in? And really anything below the line after you age standardize, we're really seeing no growth, or if anything, in per capita terms, less growth over time. Next slide. I think this is the second to last slide, but this is looking really at the same thing, looking at geography of the state and healthcare spending. But now we're looking at spending per beneficiary for the 3 main payers. And for the out-of-pocket, it's just spending per capita, I guess. But again, you see the kind of same patterns with Medicare having a little bit more spending right here in the Sound, or the Cascades, excuse me. So, and less on the peninsula. Next slide. This is the last slide. Sorry, it's a little looks a little fuzzy. The idea is we can go county by county, and all counties are included in the report, and ask, why do they spend more or less than the state on average? And so this is a comparison for each county. If you just take Adams County on the top left, it says, Adams County spends less than the mean of the state. And the question is, why does it spend less than the mean of the state? The top bar shows us that a lot of it has to do with less ambulatory care spending. And the orange is utilization, the green is prices, and the blue is the age of the population. So again, there's a key in the hard copy of the report, but it starts to allow us to go to each one of these outlier counties and pose the question, well, why does that county spend more or less than the rest? I think that was the last slide, if you want to click one more. So the main 2 questions, are again, this is essentially co-opting a research project that was done previously and trying to make it useful for the cost board. Are there little things we could do to make it more useful now? And then thinking big picture into the future, are there ways to do it in a, more substantially do it different in a way that could be useful for the cost board? So I know we're short on time, but if we have 5 minutes to take feedback on that, it would be especially useful.
Joe, thank you so much for this information. I think it is so fascinating that you've used survey data, national data, you've applied it to Washington, but it still is hitting home that we have a price and intensity issue, and we have huge variation that we have a duty to keep trying to understand and to level out. We got to create more uniformity in services and pricing. And yeah, so this is a great start. I'm wondering, I know board members right now are probably pretty overwhelmed, but are there any thoughts or questions or comments for Joe other than huge thank you? And I know we're going to continue this journey of inquiry and exploring together with all of the committees and whatnot. Board members, any other comments? Jane?
Yeah, Joe, just a quick question.
Yeah.
Spending, the county spending based upon where the person lives or where the services were provided?
Great question. Sorry, I didn't say that. It's where the person lives.
Okay, thanks.
Yeah.
Well, it sure does really portray visually the point Jody made about rural areas and what we need to start thinking about, how rural areas we as a state need to come to grips with. They've got to become a utility model. We've got to look at what we need to do in those regions to even things out. Anyways, all right. Joe, thank you. I know you will be back and you'll keep working with our data teams and keep exploring and journeying into this data.
Thanks, everybody. Thanks. Sorry about the rush, but glad we could squeeze it in.
No worries. Board members, you can hang in with us just a few more minutes here. Liz wanted to make some recommendations about the nominating committee, and I think we're going to call for a vote on the nominating committee.
That's right. And I'm not making the recommendations. I'm just sharing the information from the nominating committee. So just a quick reminder, there was a legislative change that changed the membership of the Healthcare Stakeholder Committee. And so this is really just taking action on that and also just some changes in membership. So I'll just go through this really quickly because I know people are ready to get on the road and get home, but we can go to the next couple slides. So thank you to the nominating committee. The legislation asked for at least 2 members representing consumer organizations, and the recommendations representing those folks are Adrienne Jones from Washington CAN, and then Emily Bryce from Northwest Health Law Advocates. The other folks that are recommended, Justin Gill from the Washington State Nurses Association, and Sulan Milnarek, sorry if I mispronounced your name, from SEIU 1199. And finally, 2 additional members, at least 1 small business, and the nominating committee is putting forward Patrick Connor from NFIB. Any questions about those names, recommendations? I know there's some folks from the nominating committee here in case there are.
I do not see any questions. Oh, wait.
One question. Well, one comment. First of all, I'm also a member of NFIB, so in approving, I don't know if I can be included in approving Patrick Connor. I do recommend him strongly. But the other thing is, in the charter, it didn't talk about these 2 other, including the small business representative. And I emailed Mandy and Sue earlier about that, but it was probably too late in preparation for the meeting. So I think the charter needs to be updated to reflect that.
We'll update the charter to reflect that.
Great flag. That was one of the items to take care of. So thank you.
Also, just really quick, could we also get sort of a breakdown of what this stakeholder committee would be in terms of number of people representing hospitals, number representing carriers, number representing providers? Just, I'm trying to get a sense of balance or not, and whether the board should consider additional consumer representatives, since there's the ability or labor ability to do that.
Here, Mandy pulled that up, but I think Jane, what I'm hearing also is that maybe a table that shows
Affiliation.
Yep. I mean, this is great. But
The representation.
Just
Yes,
representation,
right.
exactly. Yeah. We'll do that for sure.
We can't do that at this moment.
Not at this moment in time, unless you want to watch everybody toggle with Excel.
No.
But I'm sure that can be done, but it's a placeholder for next time.
Thank you.
We do know what their position is, not the position of the committee, but what the position is that they hold with an organization and who the agency and the organization is. We have a chart that we have for tracking who's the nominating committee, but we need to update it, get you some additional materials on that.
Okay, so in addition to the new members that have been put forward, there are a couple of folks that are replacing other folks. Paul Schultz will be coming on for Kaiser Permanente, and he's replacing Justin Evander. And then Nariman Heshmati will be representing Washington State Medical Association and replacing Jeb Shepard. So those are the changes to the committee. And there's also the chair, a new chair. We do have slides.
Yeah,
Okay, sorry.
we're just flipping between the slides right now because we pulled up the one document.
We already covered the charter. Lois brought that up, so thank you. So just a quick reminder, we're appointing the we're appointing chairs for the advisory committees, and the nominating committee is recommending Bianca Frogner for the Data Issues Committee and Eileen Cody for the Committee on Healthcare Stakeholders. So those are the things in front of us, and we can move ahead to the vote. Any questions?
So we're going to use a consensus process for a vote on the approval of these recommendations from the nominating committee and the volunteer chairs for the advisory committee on data issues and the stakeholder advisory committee. Is there any further discussion on these recommendations or proposed changes?
I had one other question. I'm wondering what other business organizations were contacted for this in addition to NFIB?
So the legislation as a whole for small business and a large business. We have reached out to large business organizations. We are waiting for a recommendation.
Okay.
We couldn't get a recommendation in time. They were still working through their processes because they're a little bit large businesses. So
Okay.
We're still working on that and still, awaiting a nomination from a large business entity.
Okay.
So it sounds like a couple of things to come back to next time, that slide and just more data about the representation and the updated charter.
I'd like to move us forward. Is there a recommendation to approve these recommendations?
Yes, coming from a nominating committee member.
Ready? Thank you. Is there a second?
Second.
Thank you, Jane. All in favor, say aye.
Aye.
Any opposed? Motion's approved, and we'll have more follow-up from the nominating committee. Thank you so much. Okay, thank you to the public who have been waiting patiently. I'd like to work with staff now to open the lines. I think our first public comment is, I think, Drew Oliverio, who's been waiting patiently. Drew, if you're on, if you can open up your line, identify yourself, your affiliation, and your comment for the board. While he's doing that, and maybe he's not on. He's on. We're running to go get him. I just want to remind the public that written public comments received since our last meeting can be found, or this is for the board, can be found under the 10th tab in the board materials. Public, if you're out there and don't want to speak up, you can always submit written comments to the board anytime before our meetings. And obviously, you can present it verbally. And then there's nobody that has signed up here in the room, just for the record. And Drew, are you ready to, or we haven't opened him yet?
No, he should be available.
Drew, are you on? And if so, there he is. We see you, Drew. Go ahead, and if you'll identify yourself and your affiliation.
You're on.
Oh, Drew, we can't hear you. Is that our end? You can hear us, I think.
Are you by any chance double muted? No. I was talking. Sorry.
That's what I'm saying. It's not muted.
And Drew, if that doesn't work, how could we do this? You want to call a
phone?
You want to call my phone and we'll just watch you talk on camera? And
I'll try a different microphone.
Gotcha.
That work?
Yes.
Okay. Sorry about that. Drew Oliver, I'm the executive director of the Washington Health Alliance. I did put in your packet, which I know is a couple hundred pages long, our most recent report on hospital pricing, which I think gets to part of the narrative that you discussed today. And I want to commend the work on the primary care side in terms of much more detail on how that gets funded. We did not look at consolidations and mergers per se. I think facility fees are a really important one. I agree with Greg Marchand in terms of some of it's pretty egregious, especially when you have a therapy visit that now costs, instead of $150, $650 because you got a hospital bill associated with that. In our report, if you just jump to the end of it, I think there's a couple of things. Our report is really on the price paid by two hospitals on the commercial side as it compares to Medicare, and we took the service line and then we adjusted to an RVU value, so it takes complexity and a bunch of those things into account. So it should be measuring apples and apples. And when we looked at what do we need to do next, I think we need to address a few things. One of them you discussed, charity care and giving back to the community. That is a big issue when we look at the Medicare cost reports. Charity care is typically well under 1% of most hospitals, and many of them are at 0.1%. So I think that's an issue. We understand staffing costs are an issue, but they're an issue across the country, and hospitals in this part of the country do get paid more than in others. The break-even rate for hospitals, we have to understand in terms of is an inefficient hospital, is that justification enough to pay them more? And then I think it really got, I think when we were talking about mergers and acquisitions, where leverage occurs. And in our report, which is different than others, we did include cancer hospitals and children's hospitals. And I think you'll see leverage occur in both of those areas as well. And with that, I'll stop to let others talk because I know you're well over time.
Thank you for those comments. And for board members, I think we have forwarded out the Alliance, our partners are hosting on June 6th, a much more in-depth dive into this issue around costs. So please, if you don't have that information, reach out to me and I can forward you that because we invite you to attend. It's in Seattle.
Katerina LaMarche.
Katerina LaMarche, go ahead.
Hi, thank you. My name is Katerina LaMarche. I'm a policy director at the Washington State Hospital Association. Wanted to thank you for the opportunity to provide comment. I know we're a bit over time. We received the materials yesterday, so we'll submit a more comprehensive written response following this meeting, but we did want to offer a preliminary comment related to the hospital costs, prices, and profits analysis you heard earlier this afternoon. And to answer Margaret's question, the advisory committees weren't given the opportunity to review the data, and it wasn't discussed with us or other hospital operators. I think that's what you had asked. And I think it was John, Mr. Bartholomew, who had made the comment, but we don't disagree that hospital costs are higher in Washington. I mean, labor certainly makes up the majority of costs, and we have a very highly paid healthcare workforce relative to other states. I mean, for example, Washington was just rated the 4th highest paying state for registered nurses. And we also agree that costs drive prices. And we think that those two factors should be analyzed together really to explain price and cost per patient. And when analyzed together, it doesn't look like any of the Washington hospitals are considered high profit or as having exceeded their peer group median by 10%. And in anticipation, of this presentation, we actually had our data team run this analysis using the same cost reports for 2022. And I think it might be helpful if the consultants are able to clarify peer groups and reflect actual numbers rather than just how each hospital relates to its peer group. For example, in the profitability analysis, just because hospital exceeds its peer group median by 10% doesn't mean it was actually profitable. Since most hospitals had negative profit margins in 2022, a hospital could be doing 10% better than other hospitals merely by losing 10% less than the median. So many of the hospitals that are listed in the slides as having normal or high profit, really actually had negative net income in 2022. Skagit Valley Hospital is listed as having normal profit, but it actually lost $40 million in 2022. And our financial survey from 2022, the same year, acute care hospitals statewide had a net loss of $2.7 billion or a net negative 9% profit margin. And lastly, really quickly, when looking at the 11 and 5-year trends, Washington, has above average population growth in the last 5 to 11 years. I think between 2010 and 2020, the U.S. population grew by 7.4% and our state population grew by 15%. So, one can reasonably expect higher than average increased total costs and revenues because, there is a higher than average increased population. So thank you again for the opportunity to comment and for all you staying on. I'm happy to answer any questions if you have them.
Katarina, thank you for those comments. And I know as we continue this journey of curiosity and inquiry, we are going to keep honing in on this because we keep hearing from a variety of reports about pricing and intensity. So we're going to all just continue to explore together. Are there any other?
I have Emily Bryce.
Emily Bryce.
Hi, good afternoon, Chair and members. I'm Emily Bryce, Deputy Director at Northwest Health Law Advocates, a nonprofit working to improve healthcare for Washingtonians. I want to thank you for this afternoon's materials, which offer a really rich set of information that we're going to be digging into for a long time as a health community. And I know some will find items to debate in the data, but I'm encouraged because this kind of transparency is exactly what the board is designed to do. So thank you. I'm particularly supportive of the board's continued efforts to dive into those hospital price, cost, and profit variation pieces we just mentioned. As Drew discussed, today's data is really interesting in light of the parallel analysis from the Washington Health Alliance and RAND 5.0, which Ingrid mentioned, both of which showed that average hospital reimbursement rates in Washington are over 2.5 times what the federal government finds are sufficient for Medicare. So taken together, these data sets give us a picture of where we might improve as a state. And I want to encourage us not to be defensive as we look at that information or kind of point fingers at each other, but really collaborative in how we move forward. I'd also like to suggest some context for the IHME data we heard. We did hear that Washington healthcare spending is relatively lower compared to some other states. And I want to celebrate that success, but also caution against equating relative overall spending to affordability or access. We should not set the low bar of the worst of the American healthcare system as our goal, because by many measures, our system is considered failing. So the US spends almost twice as much as other wealthy countries for healthcare, but ranks last overall on access, efficiency, equity, and outcomes overall. That shouldn't be our goal as a state. We heard earlier today that we're doing better in some places, and we do need to be considering what we are getting for our dollars. So if we're spending $51 billion on healthcare in Washington, which is more than the total GDP of many countries, why are we still experiencing so many affordability and access challenges? And finally, I know we need to be brief here today. I would welcome further discussion about the data gaps we face in evaluating consolidation trends and facilities fees as we discussed today. I think stakeholders all have different policy ideas in this area, but surely we can agree that additional data would be helpful to aid in that discussion. And per today's conversation, I'd love to see the subcommittees dig into some of these topics to share out some recommendations to the board in the future. Thank you so much for your consideration.
Thank you, Emily.
Got one more.
One more hand raised.
John Godfrey, and I am putting it down.
John, Godfrey, you're next. Go ahead. You'll identify yourself and your affiliation.
Take a minute to
Hang on 1 second. We're giving you access. There he is.
Can you hear me?
Yes. We can hear you. Go ahead.
Thank you, everyone. Good afternoon. My name is John Godfrey. I'm the Program Organizing Manager for Washington Community Action Network. As many of you know, we have a robust focus on healthcare. The board has heard the impact of high healthcare costs from our members, and I'm here to just express our excitement and suggestions around the board's focus on primary care and reinforce its urgency. Among the foremost complaints from our members is access to quality primary care. More and more, even when they have access, consumers walk away from their appointments feeling like a get them in, get them out paradigm, sometimes after waiting weeks to get that appointment and, of course, spending their copay. This paradigm is reflected in my own patient experience across various insurance plans and providers, but thankfully I've not suffered the worst consequences, and not all of our members at Washington Can have been so lucky. We've had reports of patients with missed cancer diagnoses or incidences of cardiac arrest and even death after they reported symptoms, often on multiple occasions in that primary care context. And we're assured that they just need to drink a little more water, reduce stress, lose weight, etc. which may be true, but often some things we can say are being missed here. And that doesn't mean that primary care physicians are any less eager to treat patients than before. Like, it's not about that. We recognize that providers across the board are doing the best they can operating in just a struggling ecosystem. And with this in mind, Washington can suggest increasing investment in primary care that we're so excited about. We want that to be paired with improved quality that allows more time with doctors and patients, and gathering and analyzing data as if we're short on data in this space, on the volume of patients seeing primary care physicians, the time that patients spend with their provider, and their patient satisfaction afterward with the care that they've been provided should be integral in improving primary care in Washington. Thank you.
Thank you for those comments. I believe we have heard from everybody. Mandy, I'm doing a double check. Correct. All right. So at this point, I'm closing public comment. We really do appreciate the comments, the feedback, and we will mix all that in as we plan our meetings, as we bring information forward. But please keep sending in the written comments throughout the month. And then, as always, please come and join us as we venture forward. So thank you everybody for attending today. I do think it's important to clarify one quick thing. Rand Hospital price report was released on May 13th. You've heard reference to that. There was a bit of information that I do think it's important for the board to report and to be part of this recording. There's an update on the previous RAND analysis that was presented to the board. When RAND was preparing to publish round 5 of their study, they discovered a significant difference in Washington's relative prices in comparison to the round 4 report. This prompted an additional review of the data set. RAND found that the data set that OnPoint had developed and delivered to RAND for round 4 mistakenly included some Medicare Advantage claims data. And despite the WA-PCD program's direction to provide that commercial data only. So it was a flaw. It means that the pricing in round 4 for RAND was understated. And we did have some interesting comments from people saying this looks too low. That was a year ago. This is old information, but I think we are learning that this data work is hard and challenging, and lots of need for everybody to review and comment and to double check. So that information has been corrected. OnPoint has confirmed that no Medicare Advantage data was included in the refresh of that data set that was delivered, and that the previous analysis was the only WA data product that was impacted. This error has been corrected in round 5 of the study, and it does explain the differences between RAND 4 and RAND 5 and other relative data sets at the time. So that is important for us to acknowledge, and they'll do better next time. Again, I want to thank you guys for your time today, and for members of the public that have hung in there with us. It's so important that we all, as Emily said, so lovely, we need to keep collaborating. We got into this work together. We need to come out of this work together, and we will do better if we all keep listening and hearing the feedback and whatnot. The recording and a summary of this meeting will be posted shortly on our website. And board members, please mark your calendars for July 30th from 2 to 4 p.m. We'll be meeting here again in this room. And I look forward to seeing you all at the next meeting. And thank you to our consultants and the team that keeps moving us forward. Oh, and meeting's adjourned. I have the prettiest